Welcome all to the 2021 Fellowship Symposium at the University of Wisconsin School of Medicine and Public Health. I'm Bruce Barrett from the Department of Family Medicine and Community Health. We have mostly our research fellows here who are funded by a T32 NRSA grant from the Health Resources and Service Administration, but we also have some clinical fellows who will be presenting a bit. So this is the Fellowships Symposium. If you know where you're aiming for, you've landed there. The research fellowship is headed by myself and Elizabeth Cox and Dave Feldstein, who are waving now. This will be exciting. We do this twice a year, and I always look forward to it, and I am never disappointed. The quality of our fellows and their work is just really impressive. So. You should have received an agenda. I'm going to mention that Christina Swords, are you there visually and waving at people, is the fellowship manager and can respond to chat or email if you have questions that can be managed. We also have Matt Fleming in the background. He's our techno wizard, webinar guru, WebEx guy who will be there if you have trouble. And again, chat or email to Matt Fleming might be helpful. I would like to mention a couple of the ground rules. One of them was we're going to try to let our fellows speak for their full time. And because then we'll have time for question and answer. So going from one speaker to the next is 20 minutes from start to start. And we should think of at least a 30-second transition period. We ask people to aim their talks to 10 minutes, but going up to 12 minutes is fine. So we're going to think of a timed 12-minute presentation, similar to one you might find at a national scientific conference. And Christina Swords is going to put in the chat when you are 5 minutes from the end of that 12 minutes, and if your math skills are good, that should put you 7 minutes into the talk, and then another 3-minute warning 9 minutes into the talk, and then another 1-minute warning 11 minutes into the talk, just so you know. And then we'll have the rest of that 20 minutes for Q&A, and I really hope that people are thinking while the talks are going on so that they have some good questions to ask our speakers. We also would ask you all to provide critical but helpful feedback to speakers, and there will be Qualtrics surveys available with each speaker. In the chat, there will be a link. So these links will separately go to each of the speakers' eval forms, and we really appreciate you filling those out. And then at the very end, there will also be a link, a Qualtrics link to an evaluation of the symposium as a whole, and we really want you to give your feedback because we're aiming for perfection. I think we're pretty darn good, but we're not perfect yet, and there are definitely ways to improve things. I think we still have a couple minutes before the first talk is scheduled to begin, so I would like to congratulate our graduating fellows and to welcome incoming fellows. So the only incoming fellow I'm aware of is on the top right of my screen, but who knows where on your screen? It's Asma Ali, who will be defending. There she is. Yeah, we're so happy that she has accepted our invitation to join the research fellowship in the fall once she defends her dissertation, because this is a postdoctoral fellowship and you must be doctoral to get in. And then I know Dr. Catherine Schmidt, pediatric infectious disease and research fellow, is graduating from the fellowship. She'll be presenting here, but we want to congratulate her on an excellent couple of years, and she's moving into another T32 to finish up her infectious disease training. So she'll be duly certified in triaxally certified? I'm not sure. And then now I know I'm forgetting things, so I'm going to stop right here. We have 1 or 2 minutes left. What have I forgotten? What else should we have announced?
I think you got it all, Bruce.
No, not me. I always forget something. I'm one of those absent-minded professors. Any other incoming fellows that we know of, or anybody who's leaving fellowships that we should acknowledge? Christina, am I? No? Okay. We still have 1 or 2 minutes till the first speaker, but we could probably start a tiny bit early since it's, I see all of these expectant, happy faces on the screen. So I've got the agenda up here, and I have done the welcome and opening remarks. And our first speaker will be Dr. Julie Kirsch, who is going to speak on primary care implementation challenges and adaptations related to electronic health record closed loop referral, i.e. e-referrals, to a state tobacco quit line. And if you can go ahead and share your screen and put it into screen view, and I'll shut up and let you take it away, Dr. Kirsch.
All right, so can everyone hear me okay? I'll do a quick sound check. All right, saying nods and thumbs up, that's good. Okay. Okay, now can everybody see? Okay, and I see the video now too. Okay, great. All right, yeah, so I'm excited to share my work with you all with the University of Wisconsin Center for Tobacco Research and Intervention. So this project examines implementation challenges and adaptations related to a primary care intervention that aims to increase access to smoking cessation treatment via referral to the Wisconsin Tobacco Quit Line. So there's a well-known implementation gap in the delivery of evidence-based smoking cessation treatment that impacts up to 75% of patients who smoke and visit their primary care providers annually. So that is, despite increasing treatment options to help patients quit smoking, there's been limited increase in treatment connection rates during visits with primary care providers. So closed-loop electronic referral from primary care clinics to a state tobacco quit line, which is known as E-Referral, utilizes the electronic health record to systematically deliver evidence-based smoking cessation treatment. And randomized controlled trials have shown that E-Referral increases treatment rates for primary care patients who smoke, and especially boosts treatment rates for patients on Medicaid. So for example, this figure compares the e-referral method, which is shown in gray, to the standard fax to quit method, which is shown in black, in 2 different health systems labeled A and B. And the e-referral method resulted in higher rates of referral to the quit line, which is shown on the left here, and higher rates of patient registration to the quit line, which is shown on the right. So though e-referral shows promising results, more research needs to be done to understand how to effectively implement e-referral into diverse primary care settings. And the e-referral intervention is intended to follow a specific workflow where first a medical assistant assesses smoking status. And then when the clinician sees a patient who smokes, an e-referral notification will automatically prompt the clinician to refer the patient to the quit line. And this prompt is shown here in the red text box. And if the patient accepts, the clinician will order the referral, and if the patient declines, the clinician will document refusal. And then within a 48-hour period, the quit line will attempt to reach the patient and register them for treatment. And then next, closing the loop, the quit line will document patient reach, refusal, and acceptance of treatment. And this data is then sent back to the clinic EHR, which feeds back to the clinician's knowledge of their patient's treatment status. So in 2016, CTRI began one of the most widely disseminated e-referral intervention studies. So it first began with CTRI coordinating training, technical assistance, and integration of the Wisconsin Quit Line within 2 Wisconsin health systems covering 26 primary care clinics. And this project therefore allowed for examination of different implementation challenges that might arise when it's implemented in diverse primary care settings. So next, in the pilot study phase to test out e-referral, It was tested out in 2 clinics, 1 in each health system. And then communication between the research team and key stakeholders was carefully documented to keep track of different implementation challenges that occurred throughout the pilot phase. And so stakeholders in this case included the health system leaders, clinic IT staff who were involved in making changes, the quitline personnel, clinic managers, clinicians, and medical assistants who were all involved in the feedback process. And then adaptations that might have occurred based on challenges that arose were documented, and their impact on the intervention was assessed with ongoing quality monitoring and coordination by CTRI outreach and research personnel. And then during the experimental study phase, half of the remaining clinics were randomly assigned to e-referral, and the other half were assigned to fax referral for comparison. And then again, throughout this process, implementation challenges were documented and different adaptations that occurred, and their impact were tracked by the research team who coordinated communication between all entities. And so for this particular project that I'll be presenting on, I applied a case study approach to better understand what challenges arise when the e-referral program is implemented in multiple clinic settings, and when and what types of adaptations occur throughout this dissemination and implementation process. So this table lists the different challenges and adaptations that were observed throughout different phases of the project. Adaptations were characterized according to the model for adaptation design and impact. So this includes characterizing adaptations based on what was adapted and the nature of the adaptation, when the adaptation occurred, and then who is involved in the decision-making process related to each adaptation. So the first type of challenge related to obtaining initial buy-in for the intervention from health system and clinic leadership. So to address this challenge, the research team offered proactive outreach and financial support for IT system development. The research team also identified unique barriers faced by each health system and allowed for flexibility in how the e-referral was implemented. Additionally, it was important to emphasize how the e-referral intervention fit with health system goals of improving meaningful use of the electronic health record. The second type of challenge related to the establishment of different data sharing agreements between the health system and an outside entity, the state quitline in this case. So CTRI had to adapt to this challenge by coordinating legal contracts between those 2 entities and ensuring that data sharing was HIPAA compliant. The third type of challenge related to configuring the e-referral program to health system specifications related to their IT. So to address this challenge, each health system underwent multiple iterative testing of the different EHR modifications that were made. And the research team also coordinated numerous trainings with IT staff, clinicians, and medical assistants to make sure everyone was on the same page. So next, clinician user acceptability emerged as a key major implementation challenge. So the e-referral notification was set as a hard stop, so meaning it could not be bypassed until a response was input. So this format, in some cases, was inconsistent with some clinic cultures, where clinicians would like to preview a patient's chart and could not bypass the e-referral notification that would pop up. And although a hard stop is an effective way to ensure that smoking is systematically addressed, it frustrated clinicians who felt it took away their autonomy and choice of when and how to offer treatment. So to address this hard stop issue, one adaptation that was made was adding a defer option so that it could be addressed at a time more suitable for the clinician. Finally, another key implementation challenge was that e-referral in some cases conflicted with established workflows at some primary care clinic settings. So the intervention for some clinics shifted the task of providing smoking cessation treatment from the medical assistant to the clinician. So some clinic managers and health system leaders wanted to reduce clinician demands by having medical assistants engage in the protocol. However, research on the intervention has shown that it is clinician involvement in particular that most effectively increases patients' treatment acceptance. So given the importance of clinician involvement, the role of the clinician was emphasized during training. And to also minimize clinician time, the e-referral process was worked on to be more streamlined. And then another important adaptation was the provision of feedback to clinicians regarding patient connections to the quit line and treatment outcomes so that they could more directly see the impact of that intervention. So overall, this case study found that suitable adaptations depended on repeated observation and documentation of challenges. And adaptations required a central entity, CTRI, to coordinate communication between stakeholders. And so adaptations were found to be necessary throughout both the dissemination phase and the implementation of e-referral to relieve tensions between standard practice and intervention workflows, and to also reduce clinician burden. So one limitation with this current work is that I did not directly examine the influence of these adaptations on potential implementation and intervention outcomes. So in future work, I'll examine implementation outcomes such as clinic staff attitudes towards e-referral, and as well as clinician engagement in the intervention. And intervention outcomes will include looking at changes in connection to e-referral and treatment rates, both before and after adaptations were made. And then another aim is to follow up the implementation of e-referral over a longer period of time to test additional patient, clinic, and health system factors that influence long-term sustainment. And then to also examine whether additional challenges arise that require further adaptations. So with that, I'd like to thank you all for your attention, and I'm looking forward to your questions and feedback.
Thank you, Dr. Kirsch. We've got a good 8 or so minutes before the next speaker, and please. Oh, there goes my timer. Please go ahead and unmute yourself and ask your question.
Hey, Julie, that was just a fantastic talk. And for me personally, so timely because we're working on a grant to implement e-referral to diabetes education resources and supports for people who are struggling to manage their diabetes. I wondered if you had any knowledge or had looked yet at patient refusals or had any hint of where you're headed with that, because one thing we couldn't find was much information about how frequently patients actually refuse and if they accept, whether or not they actually even go to the service. And maybe you're not there yet, but just really curious about it.
Yeah. So, I mean, although it did boost treatment access from 1% to 5% among all patients who visit, there's clearly is still a lot of room for improvement. And I believe, so the first, so that figure that I showed, the columns on the left kind of give an idea of what the rate is of refusal. So still, I believe 2/3 still, refused access to the quit line. And Danielle, you can correct me if that sounds accurate.
So one challenge is with the defer option added, it was possible for there to be ambiguous outcomes, right? We don't know if the patient refused or if the provider just decided never to raise it. And that was actually fairly common. For the provider to note that the patient refused was less common. But there are falling connection rates in quitline referral that used to connect about 50% of the time. Now across the nation, quitlines connect with people who are referred to them only about 1/3 of the time. And so that is an increasing challenge in getting people to follow up on their referral, even when you do proactive outreach to the patient following referral.
That is absolutely fascinating. Thank you for sharing that. And I'm assuming that the utilization, as you said, somewhat was driven by who was going to pay for it.
You know, with the state quit line, it's free to the health systems because the state covers it, and the state pays for each referral received and each service delivered. And that is, of course, not going to be true for something like diabetes education. So that is going to be a challenge.
That was the barrier to this, was the proportion of patients who, not that they weren't covered, but it was unclear to the patient and the staff who would be covered, which is another fascinating barrier. But great talk, Julie. I can't wait to see the next stuff out of this.
Yeah, thank you.
Julie, one question sort of following up on what Elizabeth's question was. So you have some evidence that if the clinician contacts the patient, that has results in a higher connection rate than if some of the staff connect with the patient. What is the data behind that, and how big of a difference is there? And if you factor into the issue about deferral, if there's a large number of deferrals from the clinicians, but you can still get an acceptable response rate from clinic staff contacting the patient, would those balance out?
Yeah. So that largely comes from, early intervention research in looking at the specific workflow of having the clinician engage with the patient. So I think there does need to be more research in looking at the differences between the medical assistant and the clinician referring the patients, because I don't think that has been as systematically examined. Yeah, I think that's a really good question moving forward. And we do know that one of the health systems decided to swap and have the medical assistant engage in the referral and the clinician just do the standard care. So it'd be interesting, although it's not really a direct comparison because they're two different health systems. So, but one of the health systems did really agree and say that, yes, it is important for clinicians to be the key provider here and to engage with the patient.
Right.
Julie, I really enjoyed your presentation, and I wanted to just tell you that about 6 years ago in pharmacies, we did a randomized trial with several Walgreens pharmacies in which we had the pharmacists make a referral exactly like you're talking about. But we did one thing differently, which is that we tried to sort on which patients would be most likely to want to do this by asking, can you pick a quit date in the next 30 days, which from the trans-theoretical model would put them in the preparation stage, so that it took best advantage of the clinician's time, because those were the folks that were most likely to make the change then. And it worked out really well. So just one more thought on that. But I really enjoyed your presentation. It's great.
Yeah. I mean, I think the key thing here is, the systematic component is also really important, because I think there's emerging evidence showing that even if you engage patients who aren't quite in that preparation stage, who may be willing more to reduce smoking or not, I think it's also important to engage those patients as well, because you might be missing a large chunk of patients who still benefit from some sort of engagement and treatment.
Julie, I had
one more question. Go ahead.
Julie, I had a question about the, you said two health systems, the types of health systems these were, and if you noticed any difference between clinics, if you looked at that. So the potentially barriers, we know that even within a healthcare system, clinics don't function the same way. So whether you noticed that there were other barriers based on either healthcare system to healthcare system or within clinics within a healthcare system that could account for some of the difficulties with implementation.
Yeah, and I think one of the key differences within health systems across clinics was that some were teaching-based clinics, which had very different. That's where one of the issues with having the hard stop and the inability to preview a patient's chart, because with trainees, it's important for them to, it might be something that they engage in to preview a patient's chart, and so that caused some issues there. But yeah, I think that's another next step, is to look more carefully at different clinic factors and health system factors to see how that impacts engagement and different implementation issues.
So I would like to ask everybody to, one of the things I really miss about having this in person was the spontaneous applause after talks, when people are in the same room together, and the smiles and the body movements and everything. It's a different situation. So please show your appreciation in whatever form you do over the video.
Thanks, everybody.
Really good work. It's so good to have you in the fellowship. And I'm going to admit my big mea culpa here. Dr. Christina Swords, who's our fellowships manager, prepared some excellent introductory slides that I was supposed to be using during the first 10 minutes. So I also forgot to tell you where the bathrooms are, but I guess you'll have to find those on your own. And I forgot to tell you that we would be having a break, a 25-minute break from 10 a.m. till 10:25 a.m., at which time I will be showing those slides that Christina prepared. And with that, I would like to move on to our second speaker, Dr. Jane Everett, who is going to be speaking on the purpose and process of developing a distress protocol for qualitative research study. And looks like she's showing us the slide, and I'll shut up and take it away, Dr. Everett.
Great. See that okay? Perfect. Well, great. Well, thank you, Bruce. So I am a first-year primary care research fellow, and excited to share with all of you today to start a bit of a dialogue around considerations for developing and evaluating a distress protocol for qualitative interviews. So in the next 10 minutes, aim to answer these questions for you, starting with some of our motivations for developing a distress protocol, and then talking a little bit about how we developed it, taught it to our team, and evaluated it for the virtual supportive cancer care study. So many, if not all of us, have written IRB applications and human subject consent forms that include statements about risk to participants. It is widely accepted that researchers have an ethical obligation to identify, minimize, and address the risk of research-related distress. And this is particularly important when research involves recalling potentially traumatic or aversive events. While the literature shows that a minority of participants express distress after an interview, and positive experiences tend to be much more common than negative ones, it remains best practice for researchers to really be prepared. And so the development and use of distress protocols is one important avenue for reducing risk to participants in qualitative research interviews. So what does this really look like? We reviewed the literature and found only a couple of examples of published protocols, and most iterated from the original that you can see here on the left, which was developed by Claire Drucker and her team for a study on adolescent dating violence. And in that study, they had mental health clinicians who were doing the interviews. So in our literature review, we identified 4 major opportunities that we felt like we could contribute to the distress protocol literature. As expected, distress protocols are much more common for research on sensitive topics like suicide, interpersonal violence, and sexual trauma. As I'll note shortly, there are topics outside of these areas that also warrant the use of distress protocols. We found that existing protocols in the health sciences especially tend to focus on patients' experiences, and we saw a need for protocols for other types of participants, such as clinicians. In addition, we found very little on how to use and debrief protocols on research teams, including how to teach new to practice researchers, such as students. So we set out to create a usable and teachable schematic that gives interviewers specific language they can use in the case of a participant's distress. Our specific aim was to develop a comprehensive and adaptable distress protocol that could be tailored to patient, care partner, and clinician participant groups. We developed this for the Virtual Supportive Cancer Care Research Study, which is a multi-method study examining the nature of virtual supportive cancer care during the COVID-19 pandemic. From May to December of 2020, members of the VisionCare research team conducted 60-minute semi-structured interviews that took place virtually with 17 clinicians, 18 patients, and 3 care partners. We felt like it was particularly important to thoughtfully develop and teach our team how to use a distress protocol, given the context in which we were completing this project, as well as the nature of the topic. As we are all intimately aware, and emerging research this year has begun to illuminate, the pandemic has amplified anxiety, fear, and social isolation for people living with serious illness. Families and friend care partners are potentially experiencing both greater caregiving demands as well as social isolation. And we all know that the possibility of clinician burnout and distress is high. So mindful of the global trauma and the uncertainty in care delivery, we felt like research invested in the experience of virtual supportive care during the pandemic required special attention to participants' potential distress. So we co-created a distress protocol with an oncology social worker. Her expertise in cancer care and intimate knowledge of the landscape of available resources during the COVID-19 pandemic helped us to assure that the protocol was relevant and responsive to the times. After drafting the language of the protocol that I'll show you shortly, we turned to the resource list. And as a team, we really worked together to identify what appropriate referral resources would be that would be accessible. We paid particular attention to the bandwidth of these resources during the pandemic to avoid listing agencies that were overtaxed with the increasing demands of what was happening in the city. We sought an integrated feedback from the faculty PI on the project, a qualitative methodologist with clinical and research expertise in cancer care. And through these iterative cycles of feedback, we refined the distress protocol, flowchart, and resource list, which resulted in a 3-part protocol that we were able to teach the data engagement team and then do some evaluation of. So I'll start by walking through the protocol and then touch briefly on the teaching and evaluation components. So part A offers the interviewer structured language in the case that a participant appears or expresses distress. We simplified this into 4 steps: assess, pause and reassess, stop or continue, and referral. One of the reasons that we outlined the steps in this way was to ensure that the ethical principle of autonomy is upheld. While assessing a participant's distress is critical, as an interviewer, you don't want to immediately stop an interview in which a participant becomes upset or tearful. Instead, as interviewers, we aim to create a safe and authentic space that welcomes emotions of all kinds. So we structured the tool in a way that checks in with, but keeps the participant in the driver's seat to decide if, when, and how they'd like to proceed with the interview. In this way, we maintain the participant's autonomy while upholding our commitment to non-maleficence as researchers and in many cases as clinicians. So part B provides direct language and resources for connecting and referring people and care partners receiving care. Again, we focused on maintaining participant autonomy, structuring the language in a way that assured that participants had agency to make their own decisions about how they wanted to be connected. We triaged referral resources, starting with asking about the primary cancer care team and offering to help connect them. Given the context of the pandemic and the potential for community resources to be overextended, we decided to focus on internal resources for both primary care and primary mental health care services. As researchers, we also have a duty to uphold confidentiality and assure that a participant's research participation does not affect their healthcare in any way. We included the highlighted language here to emphasize this point and remind both participants and interviewers that all information shared in the interview is confidential. We created a separate resource list for clinicians, which includes resources for employees, as well as language about connecting clinicians with their primary care and mental health care providers. Again, we thought it was important to include language about confidentiality and research participation not affecting people's employment. Final part of the distress protocol provides the contact information for the faculty PI as well as the co-PIs. And in the case of a participant's distress or referral to resources, the interviewer would be responsible for contacting all of us to debrief and determine next steps. This could also include being in touch with the IRB. So once we created, refined, and finalized the distress protocol, we trained members of the data engagement team on how to use it. Training supplemented training on informed consent and qualitative interviewing. And we used role-playing techniques to simulate participant interviewers and give data engagement team members an opportunity to practice employing the protocol. So in the 36 interviews that we conducted for this study, we did not need to invoke the distress protocol at any time. This corroborates other studies that have likely found that participants generally tolerate interviews on sensitive topics well. Nevertheless, the interviewers for this study valued having the distress protocol. As one data engagement team member expresses in this illustrative quote, "Having the distress protocol gave me the confidence to explore the difficult or emotional themes of supportive care during the COVID-19 pandemic with participants. I knew that if someone became upset, I would know how to handle the situation in a dignified and respectful way with the protocol's guidance." So from this process of developing and evaluating a distress protocol, I'd like to suggest three major implications and future directions. Distress protocols are integral to carrying out ethical research endeavors, especially for collaborative research teams and new to practice researchers. On a research team with several interviewers, distress protocols could be useful to help standardize how interviewers respond when distressing situations arise in data collection. As we discussed and debriefed with the data engagement team, we also found that the distress protocol may be particularly important for clinician researchers who wear multiple hats. How someone might address distress in a clinical setting may be slightly different than in the research context, where distinguishing between research and clinical care is important. We believe that the distress protocol could be an underused tool for speaking about some of these role differences. And finally, future research can explore the efficacy of teaching and utilizing this protocol in other contexts and content areas, including how investigators can adapt the protocol to reflect accessible resources in their own research settings. I want to just conclude by thanking the really great team that worked on this project, in particular my co-PI, Claire Whitney. We're working on submitting the process and outcomes of our distress protocol development for a publication this summer. And with that, welcome your questions and feedback. Thanks so much.
Thank you, Dr. Everett. This is such important stuff, and in many areas, clinical as well as research. Questions from the audience? By the way, you hit squarely in the timeline, exactly like 11, right between the 10 and 12 minutes. I just love it when people make their timelines. If no one's popping up, I'm going to ask what you think about. So this reminded me, your distress protocol reminded me of skills that clinicians and even clinic staff, front office staff and nursing assistants for room patients and everybody who works with other people really can learn, like around de-escalation or bystander intervention or just learning to recognize and talk emotions in a way that respects autonomy and assists the situation. So I guess my question is, where do you see that? Do you see this being developed and used outside of qualitative interview contexts, and if so, how?
Yeah, I think that's a really intriguing point. I could certainly see it being adapted for the clinical setting as a way of kind of condensing some of the therapeutic communication training that a lot of clinicians, sort of regardless of your discipline and your role, receive. I think that could be a really interesting way to apply it, particularly in thinking about, we worked a lot on the resource list to really try to understand and make sure that we weren't listing resources that we were going to send people to and they weren't going to get a response. So I think even as an exercise within clinics to think about the ways that you would sort of triage someone's distress and appropriately connect them could be a really important way to make sure that people aren't falling through the cracks.
So I think following up then on Bruce's question, as you know, we're moving for helping to promote ethical research. As you know, we're moving towards protocol-based IRB approvals through the new IRB efficiency project. I wonder if this might be helpful to make available to other investigators through the IRB for being able to use this distress protocol for unanticipated encounters in human subjects protocols in a way that could be more broadly disseminated to help other projects here at UW.
Yeah, Dr. Brazier, I think that's an outstanding suggestion. The one other comment I will make is that, as you found, Jane, it's tough to put that resource list together. And one of the real challenges for researchers and for clinics is to keep it updated, because the resources that are out there change so rapidly. And it's extremely frustrating for people who are in distress to try to access something that doesn't exist anymore. And that's not true just for like distress type resources, but even a list of dental services is a challenge to keep up. So if the IRB were to take this on, I think we'd have to figure out who was going to be the designated person to keep some sort of resource list updated, or to have a contact point where it's always available. But I think that is a fabulous idea and probably would improve our treatment of research participants. So I love it. Thanks, Jane, for the work.
Thanks so much. And yes, I love that idea. I will definitely follow up with you. I think one of the things we also are debating as we think about publishing this is how we want to think about the resource list generally so that people can apply it within their own settings. If we think about it being sort of some internal resources, some more hotline type services, and the ways that we might be able to generalize this to other settings. And then thinking about research ethics in kind of a nuanced way, we took at a couple of bioethicists on our research team and took kind of those typical bioethical principles, but wanted to make sure that we were applying them in a really thoughtful and considerate way. And I think as IRBs move towards standardized protocols, having resources that do that and that help teams to do that would be really powerful.
Jane, can you say a little bit more about the discernment of when a researcher might want to really sit with somebody's emotions and when it's appropriate to start introducing the idea that the person might want to pause on the interview? I know you and I have talked about this a lot in the work that we do together. I really appreciated in your presentation the sort of raising of that question. But I'd love to know more about the training around that line and your own thoughts about it.
Yeah, it's a really excellent question, and something that we wanted to be very mindful of as we were introducing this to our team, that we weren't inadvertently kind of pausing interviews that didn't need to be paused. And part of that was speaking about some of those clinician researcher role distinctions. We were fortunate that we were working with people who had clinical training and a couple of people who had training in mental health counseling and psychiatric nursing. So we sort of leaned on that a little bit to have those people of our team present kind of cases where they felt signs that they looked for in their own clinical practice that could help our more newer to practice researchers kind of envision what a distress of a certain threshold would look like that would warrant this type of pausing. And so we walked through some kind of cases of that in the training so that we weren't preemptively pausing interviews. We were also fortunate to have a team of people who I think naturally we're kind of comfortable with sitting with emotion. So in this particular setting, I think that helped allay some of our concerns that we were going to have a lot of interviews that were stopped. So we did kind of come up with potential scenarios that would help people to recognize distress. And then certainly in our interview guide and sort of the intro, we talked a little bit about ways of making the interviewer feel comfortable. So questions if they didn't want to answer them, if they wanted to take a break. So also prefaced the potential later use of the distress protocol with some information for the interviewee that would make them feel like they also could indicate that they would like to take a pause or would like to have referral to resources. So I think it was a combination of training using cases and then also structuring a whole interviewer experience around this idea that the distress protocol might be employed, but doesn't need to be invoked in all situations.
I wish we could keep going because this is fascinating, but we do have a timeline. So I'm going to call it there, and please signal your applause in whatever electronic or online form you would like. Thank you so much. This is such important stuff. And yeah, we'll get in touch with the IRB. I think that's a great idea. Our next speaker, and this would be the penultimate before the break, I think, meaning there will be one more after Dr. Katie Schmidt, who is going to speak to us on genotypic distribution of rhinovirus infections in healthy children 4 to 7 years of age. The year of respiratory infection, you all got to know as much as possible.
All right, can everyone see my slides here? Good, hear me okay? Perfect, got some thumbs up, great. All right, so as Bruce had mentioned, so hello, good morning. My name is Catherine Schmidt. I am a primary care research fellow, a pediatric infectious disease fellow, and a master of public health candidate. Today, I'll be presenting my research on the distribution of genotypes in childhood rhinovirus infections. Yeah. All right, so first I will outline basic rhinovirus nomenclature that will be useful for you to follow along while I talk about my research. Following this, I will briefly discuss rhinovirus infections during the COVID-19 pandemic. Then I will provide key information about rhinovirus infections in children. After this brief introduction, I will then go on into more details regarding my particular research. So for rhinovirus nomenclature, there are really 3 different species of rhinovirus with A, B, and C. They usually get abbreviated as RVA, RVB, and RVC. Within the different species, there are over 150 different genotypes identified by numbers following the species type. For example, the very first one on the top left of the semicircle is RVB6, meaning that it is within the species of RVB and the genotype is B6. So I want to briefly mention rhinovirus infections during the COVID-19 pandemic, because this has been rather interesting, I think, for all of us throughout the past year or over a year. And outside of SARS-CoV-2, there has been a decrease in other circulating respiratory viruses, especially influenza during this past respiratory season. So despite this observation, rhinovirus has continued to circulate. So for comparison to influenza, the diagram on the right here is a report from the Wisconsin State Lab of Hygiene, tracking percent positives of influenza from 2019 all the way to March 2021. As you can see here, there's been a dramatic decrease in influenza cases over the 2020 to 2021 influenza season. But really in regards to rhinovirus infections is we've continued to see circulation of rhinovirus throughout this whole time along with the SARS-CoV-2. So rhinovirus infections circulate throughout the year and can be either asymptomatic, so where the child or adult has no symptoms whatsoever, or symptomatic. For the symptomatic infections, they're a common cause of upper respiratory tract infections in children and adults. Rhinovirus can also cause lower respiratory tract infections And the people that we typically see these lower respiratory tract infections are those less than 2 years of age presenting with bronchiolitis, asthmatic patients presenting and resulting in asthma exacerbations, and those that are immunocompromised. Rhinovirus infections really result in type-specific immunity, with rhinovirus types A and B having temporary immunity, whereas recent research has suggested that rhinovirus type C provides more longer-term neutralizing antibody protection compared to A and B. This temporary and waning immunity over time, especially with A and B, results in a wide variety of rhinovirus infections and reinfections throughout a person's life, especially if you think about how many different types of genotypes that there are of rhinovirus. So research on rhinovirus infections in children have focused on bronchiolitis, asthma exacerbations, and those requiring hospitalization. There's really limited information about these infections in healthy children older than 2 years of age with upper respiratory tract infections in the outpatient setting. So this is where my research comes in, is to really help to understand more about the epidemiology of rhinovirus infections in these children where there is limited information. My study objective is to identify the distribution of rhinovirus by species and genotype in both symptomatic and asymptomatic children older than 2 years of age over multiple respiratory seasons. There have been a few studies of children in daycare settings, but really they have only followed them for one particular respiratory season, not over multiple respiratory seasons. So in order to do this, I used a secondary data set that had already been collected by Dr. Elledwald, Dr. Greg DeMurray, and their study team. Their study is a prospective cohort study that followed healthy children 4 to 7 years of age from 2 pediatric primary care clinics in Madison, Wisconsin, between the years of 2012 and 2017. After study enrollment, each participant was followed for 1 year. Those with congenital or acquired immunodeficiency, craniofacial abnormalities, cystic fibrosis, allergic rhinitis, or a history of chronic sinusitis were excluded from the study. Nasal samples were collected via nose blow technique at the following times throughout the year. At study entry and 4 asymptomatic surveillance visits, which in my results will be labeled as surveillance. Then there were also acute symptomatic visits that happened 3 to 4 days after an upper respiratory tract infection or URI symptom onset, which are labeled as acute, and recovery visits, which was about 2 weeks after URI symptom onset. These nasal samples were analyzed for the following respiratory viruses by multiplex polymerase chain reaction. Further sequencing methods were done to identify rhinovirus species and to differentiate them from the enterovirus species. And then further sequencing was done to figure out what specific genotypes were present in these samples. So overall, there were 290 participants with 1,570 nasal specimens collected. When looking specifically at those with rhinovirus positive specimens, there were 207 participants with 486 positive nasal specimens. The demographics, or the tables shown here, are for those with rhinovirus infections. What we can see is that majority of the participants were white, non-Hispanic, had higher maternal education, and had other children present at home, in addition to the study participant. There were 121 different genotypes identified that circulated throughout the study timeframe. 45% of the rhinovirus infections were identified at the surveillance visits and 41% at the acute symptomatic visits. The distribution of these different genotypes are shown in the graph here, separated by species and type of visit. Rhinovirus A was the predominant serotype, followed by C and then B. There were 56 different rhinovirus A genotypes, 16 for rhinovirus B, and 49 genotypes for rhinovirus C. The table on the right shows the percentage of circulating genotypes in a given year that were unique compared to the previous year. Rhinovirus A and B had 80% of new genotypes circulating compared to the prior year, and rhinovirus C had about 70%. When looking at the acute symptomatic visits, there were 63% of new circulating genotypes compared to the previous year. Due to the small number of samples collected during 2016 and 2017, these years are not displayed in the graph or table shown here. So the next steps in the study are really to look at the relationship between the participants' symptom scores and rhinovirus species. So symptom surveys were collected on acute visits or throughout the acute period on days 3 to 4, 7, 10, and 15. They looked at these different symptoms here. And so I really want to look at the relationship of these different species and whether there was any differences in the symptom severity of the children. In addition to that, number of missed days of childcare or school, depending on their age or work, were collected. So I will also be evaluating whether there's a difference seen amongst the different species. So in conclusion, this study demonstrated a diverse distribution of rhinovirus genotypes in both symptomatic and asymptomatic children. There does seem to be a high percentage of new circulating genotypes monitoring from one year to the next. Understanding the prevalent rhinovirus genotypes and annual variation may help to guide future therapies or vaccines that target this common respiratory virus. I would like to acknowledge the following people involved in this study: with Dr. Ellen Wald, Dr. Greg DeMurray, Dr. James Gurn, Samantha Omdenfor, the pediatric study nurses, and the funding to support this study. So thank you all for listening today, and I would be happy to take any questions at this time.
Thank you, Dr. Catherine Schmidt. Very, very good stuff. As you know, I've been looking at colds and respiratory infection for a long time, and I just love learning about it, especially this year. If you could unshare your screen, and we'll ask for questions from the audience. We've got just under 10 minutes before our next speaker. Well, I'll start off. Your last slide suggested that we might be able to come up with a vaccine for rhinovirus, but with those 150 subtypes, the conventional wisdom is that wouldn't be possible, but I don't really know the molecular biology of these bugs very well. Are there protein structures that could potentially be cross-targeted by antibodies, by the immune response, such that some kind of vaccine someday could theoretically be possible?
Yeah, that's a great question. Very challenging, especially with all of the different genotypes within and then the species difference too. So Dr. Gurn came out with a recent paper that was quite interesting, talking about rhinovirus C and neutralizing antibody protection. So Dr. James Gurn is, he works here at the Allergy Immunology here at UW and is a very world-renowned rhinovirus researcher. And so he came out with a recent study that was looking more at this longer-term protection with rhinovirus C in particular and these neutralizing antibodies. So is looking at more details about whether that is feasible. But yeah, for overall, for all of the different species, I think that would be very challenging to do. And Dr. Conway is on too, who is involved in a lot of vaccine work as well. So I don't know if he has any thoughts or discussions that have happened.
Yeah, it's all about trying to find conserved epitopes. You know, this is the same question with trying to find a universal flu vaccine. You know, and there's more and more progress being made on trying to use like the conserved M2 protein that seems to remain relatively stable. It's not particularly immunogenic, but now with some of this new mRNA technology, there is a possibility of creating a bypass that actually then generates immunity. And so this is opening up a whole new field. And so this is why Katie's work with all of these collaborators is really important, because if you can identify what the circulating rhinovirus types are and then try to find conserved epitopes that may not be, you know, the ones that typically the immune response is directed towards, you could actually come up with a stable vaccine. And so this is really just started to take off in the last couple of years, but these mRNA vaccines, this is really, I think, where the future may lie. So this type of work, while it may seem observational, actually really does direct a lot of potential research going forward.
So Catherine, I wonder also whether or not in the cohort you have information about where the children live, and whether or not in terms of looking at the geographical distribution laying over the genotypic information is whether or not you can identify whether certain types of strains tend to circulate in certain communities. Again, the idea that partly driven by what we've learned from COVID is that there are strains that tend to circulate in certain types of communities and have reservoirs in that communities, and whether or not you might be able to get additional information from your very detailed genotypic information laying over some geographical information about where these individuals are infected.
Yeah, thank you for that observation as well and thinking about it. So all of them were from Madison primary care clinics, which majority of them live within Madison. I'm not sure we collected that information, although we do have their records, so could potentially look back and see because we have all of their contact information. But that was not something that was collected on the initial information of these patients.
Another quick question, Katie. John Tempty here. Actually, two questions. Number one, did you guys look at all for co-infection? And number two, were there any measures of viral load between symptomatic and asymptomatic?
Yeah, thank you, Dr. Tempty. Yes, for the 10-minute talk, I didn't have enough time to go through all of the co-infections that happened. So really, the ones that I was focusing more on was really in the acute infection. You know, with rhinovirus infections, as you're aware, there's a lot of discussion about how much influence in acute upper respiratory infections does rhinovirus have. So in those acute rhinovirus positive patients, about 10% of those had co-infections with non-rhinovirus respiratory viruses. And then very minimal of them had co-infections with rhinovirus themselves. So about 3% had co-infections with another type of rhinovirus at that particular time frame. So that had to do with, yes, the co-infection question, which I just didn't have enough time to address at this point. And sorry, what was your second question?
Well, it had to do with viral load, no matter, not a very accurate measure, but any trends between symptomatic and asymptomatic.
Yeah, there wasn't viral load that was done. What was done is actually we're looking at bacterial load because the study came out of a sinusitis study. So they were trying to look at complications of respiratory virus infections. And so we do have some information about bacterial loads in different kids as they're symptomatic or not, but not the viral loads in particular. Thank you.
Okay, thank you.
So I've got another one for you, I guess, theoretical, I suppose. But so we've learned how important respiratory infections are this last year. I wish that, no, I don't wish that COVID had happened 20 years ago, but if it had, the NIH might have actually put money into acute respiratory infection, common cold. Right now, Alzheimer's is big and addictions are really big, but I wouldn't doubt that the country and the world will be trying to figure out infectivity a lot better in the next decade compared to now. Ethically, it's been thought that purposefully infecting people with rhinovirus is okay. That used to happen in Wisconsin for a couple decades with Elliot Dick, and then Jim Gurn, I think, did some of that stuff under Bussey's lab, maybe, and certainly down at Virginia and a few other places that we've been doing experimental, at least in college students, people at low risk. Do you see a role for that? Since I assume that most people will think it's unethical to purposely infect people with influenza or certainly with SARS-CoV-2. But do you see a use of cultured rhinovirus infections to help figure out infectivity to help improve public health?
Yeah, that gets really complicated in pediatric patients in particular too. So in addition, there's just a lot more IRB and concerns about doing something for pediatric patients. And so I don't envision that will be something moving forward. I would envision that would potentially be in the adult population before it ever trickles down to the pediatric population. But that's just my thought.
We have time for one more before our last speaker before the break.
I just had a quick question. You said that obviously the influenza rates were way down during COVID, but the rhinovirus were not. That's actually surprising. I didn't realize that. What are the thoughts about why that may have occurred versus influenza?
Yeah, that's a great question. I was trying to find a good graphic. There's some from other countries that are published at this point that shows kind of the circulating respiratory viruses. And what they show is rhinovirus really, as we went into lockdown or other countries went into lockdown, rhinovirus kind of plateaued and went down pretty low. And then as we sent kids back to school and things opened up slightly more, we saw kind of a really big jump in rhinovirus, even despite a lot of these mitigation strategies. So there's a lot of research, and Dr. Tempty and Dr. Conway can probably speak to it, about influenza in particular, and how mitigation strategies have been shown to really drop down things. But rhinovirus really, I think that was a surprise to a lot of us that it continued to circulate as much as it did. So I don't have great thought processes in regards to why particularly rhinovirus. Yeah. Bruce, you were going to say something. Sorry.
That makes good sense. And during the break, it might be a great little conversation, actually. You don't have to go away and not come back for 25 minutes. You can actually stay online and talk to each other. But with that, let's send our applause to Dr. Schmidt for a really outstanding work. And wish her well in her next fellowship, starting July 1st, maybe. Our next and last speaker before the break is Dr. Tana Changzowat, who is a family medicine physician who we were very lucky to recruit here from Kansas. She will be talking about addressing disparities in rates of sexually transmitted infections through a mail-in self-swab collection method for screening. If you're there and can share your screen, Dr. Changzowat, welcome and go ahead.
Yes, thank you. Let me get my PowerPoint open, and I'll go ahead and start. Okay. Can you see my screen okay? Okay,
yes.
Great. And I have lost your boxes, and so I cannot see you all, which I will then end the share screening so we can have a discussion afterwards. And so, yeah, so thank you for the introduction. My name is Tana Changzowat. I'm a family medicine trained physician and a first-year primary care research fellow, as well as an MPH student. And for my fellowship symposium, I'll be talking about addressing disparities in rates of STIs through self-swab collection and mail-in methods. And to kind of just intro what this research is, it's actually has not been done yet. So I'll be kind of introducing what will be done. And we are starting with just a survey to determine whether or not we can really address kind of increased disparities in STI infections through self-swab collection. So particularly vaginal self-swabs that are collected at home that then can be mailed into the clinic or to a lab for testing. And so addressing some of the barriers to STI screening through those methods. And so this is a survey, this portion of the research is just the survey to determine whether or not this is something that we should do. And so, okay, and so a little bit about the background and the motivations and why we decided to kind of go along this route is that there has been kind of an increasing concern regarding the rising rates of gonorrhea and chlamydia in the United States, particularly among adolescents and young adults. And from the CDC, chlamydia particularly has kind of an increasing rate from 2000 to 2019. And as we can see here, kind of a steady incline with women definitely having more infections than men. And then here's kind of the age breakdown. As we can see, a much higher rate in the 20 to 24 age groups. And then the younger 15 to 19. And so looking at gonorrhea, we also see kind of a steady incline from 2013 to 2019. In this case, actually, men have more infections. And then we actually see disparities with by race and ethnicity, with Blacks and American Indians and Alaska Natives having higher rates of gonorrhea infections. And so based off of kind of these guidelines, the USPSTF, as well as kind of, you know, the CDC, the AAFP, and ACOG all more or less agree with the recommendations for screening of women 25 or younger and older women who are at increased risk for STIs to do chlamydia and gonorrhea screening, which is a grade B recommendation, whereas men is kind of a grade I for insufficient for recommendations. And so kind of the collection methods that we're familiar with. So the, you know, one that's kind of commonly done is the clinician collection, where women would come in, get a pelvic exam with a speculum for an endocervical or a vaginal swab. And then there's the self-collection vaginal sample, which is the one that I'm talking about here, where women can swab themselves. That's usually done in a clinical setting. And then there's the first catch urine. And based on some of the data that's been out there, you know, the clinician collected in a self-swab, self-collected vaginal swab has equal accuracy, whereas both of them are better than first catch urine. And then there's also some other research that's out there that shows that actually if you had a choice between clinician collected or a vaginal swab that's collected, it's actually better to do the self-collection. And that the other two methods with the first catch urine and the clinician collected can actually miss up to 10% of cases. And so as far as the other method that we're talking about here, which is the mail-in, so this is something that's commonly done, or well, I'm not sure how common, but is available as what's considered like a direct-to-consumer home kit. And patients can order these kits online, and these are just random websites that you can just Google on home STI testing. And so as you can see here, there's a lot of them that are available. People can just order them online, have them sent to their home, swab themselves, or do a first catch urine. The methods vary between which company you're ordering from. You have to pay out of pocket, so it's not done through your primary care physician. It's not done through insurance, although it is covered by, I think, FSA and HSA. So this method, you know, does decrease the need for patients to have to go in, although it is cost prohibitive. And then going back to kind of the collection method, something I forgot to mention, you know, when you're really talking about self-collection vaginal samples, this is addressing barriers for patients that otherwise would not have a pelvic exam, either due to patient preference, you know, patients with a history of sexual trauma, gender identity, or sexual orientation are less likely to want a pelvic invasive exam for STI screening. And so usually the other two options are more ideal. And so looking at this survey, so the first aim that we're looking at is really just to evaluate the acceptability of a self-swab mail-in program for STI screening, and particularly for patients that are already established with the primary care provider. And so, you know, the direct-to-consumers, patients can order that online by themselves, but we're particularly looking at patients that are already established with their primary care clinics. And then the secondary aim that we're looking at is to determine if there are certain populations who face disparities who would benefit more from a home collection option. And so the study design we are looking at, we're planning to obtain and recruit patients from the Winger Family Medicine Clinic, which is the clinic that I'm out of, which is an Access and UW Health clinic, looking just at females and patients that are aged 18 to 24. And then we're recruiting them through telephone. They would be then emailed or mailed paper formats. We are only doing the survey in English, providing some incentives and aiming for a total of 150 participants. And so for the survey questions, I broke it up into kind of these 6 different categories. I did not include, obviously, all the survey questions. And this is just kind of a small sample of what data we are collecting. And so for basic demographics, definitely age, race, ethnicity, living situation, especially for younger populations, whether or not they live at home, they have a roommate, by themselves or with a partner. And then location, we are interested to know whether or not they are in a rural, suburban, or urban population, marital status, education, employment, insurance, or a lack of insurance. And then for gender identity, all patients that we are recruiting are women assigned at birth, a female assigned at birth, but we are also interested in gender identity. And then sexual practices and risk factors. So a lot of questions kind of on sexual orientation and practices, particularly trying to determine their risk. And so a number of partners and things like whether or not they use barrier protection. And in healthcare practices, so whether or not patients are going to their primary care provider for routine visits, yearly visits, chronic disease management, sick visits, and then whether or not they've been tested for STIs in the past, been positive in the past, and then methods that they've tried as well. And so, and then finally, questions about the acceptability for a mail-in program. So whether or not they prefer to go into the clinic for their STI screening and talk to a provider, or whether or not they would prefer and feel safer doing it from home, or would find it more convenient. And then, so definitely the acceptability for mail-in program, the questions are a lot more comprehensive than this. This is a small sample of them. And so the hypothesis is we are particularly interested to know if patients who are at higher risk for STIs, such as having multiple partners, lack of barrier protection, history of STI or self-reported high risk for STIs, younger age, LBT respondents, and our hypothesis is these populations would be more likely interested in doing STI screening from home. And so the next step, so let's, if our hypothesis is true with this survey, the next steps would then to proceed and go ahead and testing for, and actually testing patients and doing sample kits that were sent to patients. And basically that would look like, to start with, is a lab validation where we actually would need 20 positives. So that would be an estimate of about 300 patients. And we would need to do a comparison between self-swabs that are done from the clinic and then subsequently done at home within a few days of each other, and obviously prior to getting treatment if they are positive and having a 100% concordance. And so if we can do the lab validation, that we can integrate that into clinic flows, and if our hypothesis runs true in patients that are already established with primary care, clinics are willing and are more interested in doing self-swabs, STI screening from home, then this is something that we can provide for our patients. And so that's kind of the next steps and kind of the final outcomes that we are looking for. So for this survey in itself, there are some limitations. It is selection biased since we are looking at really just established patients, English speaking, and assuming they are literate, and then women only based off the USPSTF recommendations for screening. We are doing vaginal collection only, and I know a lot of some of the newer recommendations are doing oropharyngeal swabs and rectal swabs. But we are particularly interested in vaginal self-swab collection. And then obviously this is sensitive information. We're asking about gender identity, sexual preferences, and then history of STIs. And so we'll have some prompts to kind of refer patients if they need some more resources. And so yeah, that's it. Thank you. Definitely open for questions and acknowledging Dr. Cody, who's the PI, Nicole Steiner, who's our research specialist, and then Dr. Cox, who's been mentoring us, as well as the PEDS R&D committee, who is providing funding for our research here. And so I'm going to turn off my share screen since I've lost video and I would like to see people's faces, but I can refer back to the slides if anyone wants to see them.
Perfect. Thank you so much. Again, right on time, well under 12 minutes. We have about 8 minutes left till our break, and we'll open it up for questions.
Hey, Tana, that was lovely. And I know that you've been through some early research learnings in this process of what's possible and what's not. So congratulations in overcoming a lot of that. That's one of the keys to research success is perseverance. I'm curious, you alluded to the cost of some of these at-home test kits that you can order, and wow, that was shocking. But I'm wondering what the cost, if you happen to know what the cost for a clinic visit is, along with this testing for someone who perhaps is uninsured. I'm sure there are other places maybe they could go to get this done, but I'm curious what the cost comparison is.
Yeah, so actually, that's a really great question. So based off of what I've already found out, it definitely is about $70 to do just the laboratory cost. And then, obviously the clinic cost can vary from clinic to clinic. And so that the testing for patients to purchase it online is actually, I would say, comparable. The downsides to that is that it's not done through insurance, and so patients are paying out of pocket for those commercial direct-to-consumer test kits. And then for patients that are uninsured, our clinic is through Access, and so there's a discount program, and so that it wouldn't be that much out of pocket, especially since it's aligning with STI preventative care, or STI screening and part of preventative care. So we anticipate even if patients are uninsured and paying out of pocket and going through the clinic, it would be much cheaper.
Thanks for that. I think one of the challenges we see in practice is that for young adults who are still on their parents' health insurance, they sometimes don't want these things to show up billed through the clinic. And I think that's one population that these orderable at-home tests actually appeal to. I see Dr. Cody might have other comments about that, but yeah, I appreciate your work. I think it's really important to think about how we reach these populations.
Right. And like Dr. Changzowat was saying, this is actually not for diagnosing when someone actually has concerns for a sexually transmitted infection. This would be for the routine screening. And so again, anyone who has concerns for an infection would actually still have to come to clinic to get the actual testing done. So those at-home tests, I don't think that they're very specific for screening versus, I'm sure people are using them if they actually think that they have symptoms. The other thing that this would be helpful for is the CDC recommends after a positive chlamydia test that we do a repeat test 3 months after that. They don't really call it a test of cure because the likelihood would be a reinfection, but this would be another place if they've had a recent positive chlamydia test and we've done not a great job of catching them at that 3-month mark to retest. And this would be after we figure out if this is something feasible, this would be another use for that.
Definitely.
Tana, I had a question. I think this is excellent work. And when I was looking at how you were showing some of the survey, and I may just have missed it, is it looks like you're talking about home versus clinic, but not necessarily differentiating between self-swab versus clinician, swabbing. So I was wondering if you are breaking that down, because there may be people who would be okay doing a self-swab in the clinic, but not at home because of the logistics of it. But then there are other people who may just not want to do the self-swab and not be okay with that. So I didn't know if you were looking into that at all, because if they just say they don't want to do it at home, it could be because they don't want to do a self-swab.
Yeah, that's a really good question. I would need to confirm to see if we made that differentiation in the survey. And the actual next steps when we are doing the validation, it would be a self-swab self-swab in the clinic and a self-swab at home. So they'll both be self-swabbed.
Tana, thanks for sharing
I
this
do
work.
believe we do have that. We do have that distinction in the surveys, I believe, but thank you for pointing that out.
Yeah, it's just oh,
sorry.
I was just going to ask about your including gender expansive, gender inclusive language. Are you identifying patients to include based on their gender in the electronic health record? The one question I'm thinking about is based on patients that have either gone through the paperwork and legal process of changing their gender identity versus just having it changed how it's displayed. So in Epic right now, it's sort of, you can either put their preferred, or sometimes patients have actually gone through the process already and may be presenting sort of differently depending on how far they are through the paperwork and legal process there.
Yes, and so I'm sorry, it's getting a little choppy, so I think I missed a little bit of that question, but I think I can answer it. We are capturing some of the information from the EMR, but we are relying mostly on patients' self-identified responses to the survey.
I think
Did that answer your question? I'm not.
I guess in terms of selecting people to send the survey to, how are you identifying that they're women?
Oh, yeah, so it's assigned at birth. And so in the EMR, it does distinguish whether or not patients, their gender assigned at birth versus gender identity.
Okay.
But you're not selecting on that, right, Tana? You're not selecting your sample based on that.
We're selecting based on gender at birth.
At birth, okay. I think maybe Dr. Ali had a question as well.
Yeah, thank you for the presentation. I just, given the price for the kit, I was wondering if you would be also including, because I did not see that, I'm not sure if that was just like a sample of your questions within the basic demographic, if you would include the income for the patients as well.
I don't think we are including income for patients. No,
That is a great question, both income and insurance. And the insurance you might be able to get from the electronic health record, but you might also want to include some sort of income thing. I really like that idea. That's fabulous, especially since this stuff is so cost sensitive.
Definitely.
I'm thinking that this might end up being iterative and growing. So your first survey will probably be not large enough to represent all of the different groups that you would want to differentially know about their acceptability of this. That would require much larger sampling and oversampling and probability sampling and so on. But you don't want to wait until you can do that. This makes really good sense to start. And you might want to start pilot testing the actual intervention before you get the full national demographics on acceptability. But it's, what do you think about that as a stepwise, iterative, growing field?
Yeah, that's definitely been part of the discussion. We're just trying to figure out some of the logistics.
Okay, electronic applause and deep gratitude for really doing work that I think has tremendous public health, human health implications in many places. Thank you so much. And that brings us to our break. So I have I think two announcements or request. The first one is really a request. In your chat, there are links to really easy Qualtrics surveys that include Likert questions, but just a few of them, and include boxes where you can type in words. Please give constructive, helpful feedback to all of our speakers on those links during the break so that you don't forget after the symposium is over and forget to do it. That information is really helpful to them. They are obviously outstanding speakers doing really important work, and yet they can still improve. So please give the feedback in the Qualtrics. And my other announcement is anybody wants to stay on during the break and chat. I was going to put up slides, and then I thought that would get in the way of conversations. So anybody who wants to, I'm going to go get a cup, refill my cup of coffee, maybe come back, maybe converse. And then I will show those slides that Dr. Swords prepared starting at 10:20, because the next talk starts at 10:25. So at 10:20, I'll take over the screen and show the slides of our graduates and our incoming fellows and so on. So thank you all for participating in the first hour and a half of this twice annual symposium. And please take care of yourself, stretch, go outside, see how the weather is, grab some coffee, talk with each other online, and enjoy. And we'll start again at 10:20 for a couple of slides, and then 10:25 for the next talk. Is everyone back who should be back? I hope so, because otherwise you're going to miss it. Welcome to the second half of the 2021 Fellowships Symposium. Our speaker here is Dr. KJ Hansman, who finished the residency here in family medicine and has been just a spectacular contributor to this fellowship, is now a PhD candidate in the Population Health Sciences department, and she's going to be speaking to us about area deprivation share, new measure for characterizing hospitals based on patients' social needs.
Sounds good. Well, thanks for that introduction, Bruce. First, I just want to check that my microphone is working, since it sounds like there might have been issues before. Is it sounding okay?
Sounds okay. You might have
Sounds
to lean
great.
into the mic a little bit. Don't lean away.
Okay, sounds good. Well, like Bruce said, I'm going to be talking about area deprivation share and a data analysis project that I've been working on over the course of the fellowship with my primary research mentor, Dr. Amy Kind, in the Department of Medicine, Division of Geriatrics. What I'll be talking about a lot today is hospitals, hospital characteristics, and hospital outcomes, particularly 30-day hospital readmissions. And so I also encourage you, as you're listening along to my talk today, to think about how a measure like area deprivation share, which I'll be describing, might apply to primary care clinics and primary care settings when we think about how we might characterize or identify our patients' social needs. And also how a lot of the problems that I'm going to be describing here are probably best solved by some of the tools that we have in primary care and community health. So before I can describe, I'm just going to make sure I can advance. Before I can describe what the area deprivation share is, I'm going to need to introduce the concept of the area deprivation index, which is one of several indices that's used to track social determinants of health at a geographic scale. So it uses information from the census to identify factors of income, employment, education, and housing, and calculate a score by census block group, which is about the size of a neighborhood or a 9-digit zip code. It then uses that census block group score to rank nationally across all census block groups and develop an area deprivation index percentile. So then we can see severely disadvantaged neighborhoods compared to other neighborhoods across the country. A higher area deprivation index percentile is associated with more severe neighborhood disadvantage. And previous studies have found that this is a predictive and relevant indicator for worse health outcomes. So studies look at cutoff points at the 80th or 85th percentile. One study looking at hospital readmissions at the 85th percentile of area deprivation index or above found that patients were more likely to be readmitted to the hospital within 30 days in these neighborhoods, and that the rates were comparable to patients that had chronic conditions like chronic lung disease or diabetes. So how does something like area deprivation get under the skin to mediate an outcome like readmission? Well, it's likely through a variety of pathways. So it may be really related to limited access to primary and urgent care services, increased exposure to harmful environmental settings, and decreased access to important considerations for health, like food, transportation, and other community supports. But the hospitals that care for these patients are also situated within these neighborhoods and communities. And so area deprivation may mediate how they're able to perform at a systems level, thinking about their differing geographic reach or their ownership characteristics, and in particular, the burden of patients' unmet social needs that they may be serving. One study looking at all of the hospitals in the state of Maryland found that when they averaged patients' area deprivation index at the hospital level, comparing a hospital's average area deprivation index to its readmission rates showed that readmission rates were higher for those hospitals that had a higher average area deprivation index of their patients. And this is particularly relevant when we think about how payers try to address an outcome like readmission. So for example, Medicare's hospital readmission reduction program essentially penalizes hospitals for having higher than expected readmission rates by adjusting their reimbursement payments. This is adjusted for their medical case index, so the complexity of the patients cared for. And they've also started to include some social determinants of health in their adjustment as well by accounting for hospitals and their proportion of patients that are dually eligible for Medicaid insurance. But that adjustment alone does not account for all of these factors at the neighborhood level or the geographic level, sort of that area context that may be impacting what it might also drive patients' unmet social needs and the readmission to the hospital. So in my analysis, what I wanted to describe was the area deprivation share. So the burden of that unmet social need that hospitals or other systems in the healthcare setting might be facing when they're caring for these patients. I define this as the proportion of a hospital's discharged patients who were discharged to a severely disadvantaged neighborhood. And for the purposes of my analysis, I define this as being at the 80th percentile of area deprivation index or above, so that highest quintile. The objectives of my analysis were to identify area deprivation share for the hospitals in my study sample, to describe the characteristics of these hospitals across the distribution of their area deprivation share, and to evaluate the association between area deprivation share and 30-day readmissions. And briefly, this figure on the right is from the Neighborhood Atlas, which was prepared by my mentor, Dr. Kind, and is available for use in research at the Neighborhood Atlas, which is on the Department of Medicine's website. So for my study sample, this source of the data was from a national 100% cohort of Medicare claims data from 2013 to 2014, looking at hospital discharges from January 1st, 2014 to November 30th, 2014, and using baseline data from the previous 12 months to define baseline comorbidities for the patients included. Hospitals were included in the sample if they had 25 or more qualifying discharges, and reasons why discharges might not qualify or might be excluded were if the patient information was missing data to allow us to determine their area deprivation index percentile or their comorbidities, or the outcome of the claim resulted in a competing or predisposing factor. So the patient was discharged against medical advice, transferred to another acute care facility, or died during the hospital stay. So this study sample then resulted in 4,563 acute care hospitals, 4,633,434 patients, accounting for 7,195,279 discharges, again, during that period of January 1st to November 30th in the year 2014. During the study period, the average 30-day readmission rate for the study sample was 17.8%. So then looking at that area deprivation share, the proportion of patients discharged to the most severely disadvantaged neighborhoods, for the most part, hospitals were discharging a small proportion of patients to these severely disadvantaged neighborhoods. The sample median was 17%. What we're looking at here is deciles. So about 456 of those 4,563 hospitals included in the sample, broken up again based on their distribution of area deprivation share. So in the lowest decile, these 450 or so hospitals were discharging anywhere from 0 to 2% of their patients to a severely disadvantaged neighborhood, all the way up to the 9th decile, where they were discharging 39 to 52% of their patients to these severely disadvantaged neighborhoods. In the 10th decile, hospitals were consistently discharging more than half of their patients to severely disadvantaged neighborhoods, and sometimes up to 98%. So some of the characteristics that were noticeably different across this distribution of area deprivation share was discharge volume. So again, on the x-axis here, we have area deprivation share, the y-axis is qualifying discharges. And of these 456 hospitals, represented by individual dots here, in the highest most decile, discharging more than half of their patients to severely disadvantaged neighborhoods, the discharge volumes were notably lower. Another difference across the area deprivation share deciles was the race of the patients cared for. So patients identifying as Black or other race were more represented in the most disadvantaged area deprivation share hospitals. So in this highest decile, 30% of those patients identified as Black or other race. And another noticeable difference across the hospitals was where they were located in their rurality. So 63% of the hospitals that were discharging more than half of their patients to severely disadvantaged neighborhoods were located in small towns and isolated rural areas. Looking at the relationship to 30-day readmissions, I used a generalized estimating effects equations model to look at distribution by binomial readmission outcomes. So was the patient readmitted or not? And then accounted for the main explanatory variable of area deprivation share and adjusted for medical comorbidities of the patients, stay level factors like the length of stay or whether the patient was discharged to a skilled nursing facility, hospital characteristics, and patient demographics, as well as other social risk factors, and found that the adjusted odds ratio for 30-day readmissions was 1.11 and statistically significant. Another way of looking at this is looking at the marginal probability of 30-day readmission using this adjusted model. So breaking it down again by decile, the majority of the deciles were relatively similar to the study average, which was 17.8% for 30-day readmissions. But in the 9th decile, this increased to 18.3%. And in that most severely disadvantaged decile, where they were discharging more than half of their patients to severely disadvantaged neighborhoods, the 30-day readmission was predicted to be 19.1%. So again, when we think about how Medicare might adjust for the reimbursements to these hospitals, they may actually be penalizing hospitals for the unmet social needs of the patients that they're caring for. When we think about the implications of this and what do we do next, really we're going to need to address social determinants of health to improve care at all levels. And so when we respond to area deprivation from a primary care perspective, we would think about increasing access to primary care. We might also think about increasing how we integrate our services with resource navigation. So in our department here, for example, we have the Community Resource Navigator program, which works out of Northeast Clinic and Winger Clinics and helps connect patients with resources for paying medical bills, paying for their medications, accessing food, transportation, housing, and more. We also need to think about how, as healthcare systems, we're investing in community health. So how do we invest in these severely disadvantaged neighborhoods to support community supports and addressing these social determinants? And how do we advocate for change within these communities? I'll make a point that so many of these neighborhoods that we identify as severely disadvantaged now were planned that way based on racist and otherwise unfair policies in the past in this country. And so to make change now, it's going to take more than just trying to be fair now, but actually being anti-racist and actively undoing some of these policies from the past. I'm very excited to continue this research and think about the next steps of this particular data analysis, as well as applying this to my own dissertation work for my PhD in population health, thinking about how we study, again, the ways that we might respond effectively to area deprivation in the primary care and community health levels. But at this point, I will acknowledge all of the many people who have been helping me with this process through the Health Services and Care Research Program, which will soon be the Centers for Health Disparities Research, and my team with Dr. Amy Kind, and turn it over to questions. Thank you all so much for listening.
Nice. Thank you for that presentation. Again, right in the window of 10 to 12 minutes. So we have 9+ minutes left for questions and answers. Might want to unmute, or not unmute, unshare your screen so we see who's asking. But be ready to reshare if they want to look at one of your excellent graphics.
So KJ, I'll start. Thank you for the talk. It's been really a pleasure to watch how your research trajectory has grown since I had the opportunity to meet you. I wondered if you happen to be able to join the national T32 fellows presentations yesterday. And if you didn't get to, I'll just point out that there was an article suggested as a read, which was about racism in health services research. And I think it speaks greatly to the topic that you were just raising about how what the data we often have available in health services research doesn't allow us to get down to some of these structural inequity issues, or that we sometimes gloss over them. And so I don't know if you were able to be there and wanted to comment about that, but I'll also put the article in the chat when I find it again. It was great.
Thanks, Elizabeth. I was in clinic yesterday, so I missed the talk, though it sounds like it was excellent, and I'll be very excited to read that article.
Well, good. I'm glad I said something.
Yep. I think it raises an important point between the difference between identifying these problems, so being able to identify a severely disadvantaged neighborhood or identify a hospital that serves more, and then thinking about what do we do about that? How do we use that information to actually address health disparities and promote health equity? So that's such an important aspect of, we can make all the pretty maps and graphs in the world to show that there's a problem, but we have to take it beyond that step of describing the problem and thinking about how do we actually address a problem like area deprivation.
Do you want to share your thoughts about how we're going to do that?
So I alluded to some of the potential solutions that I can think of. I think one of the biggest things that we need to think about as researchers and as healthcare systems is who are we involving in these conversations about planning and where we invest our resources. I can come up with ideas, but I'm just one person and I don't represent a full view of what the lived experience is in these communities. And so that's that element too that I'm really excited about as future directions in research, using something like the Area Deprivation Index to as essentially a vital sign to say, you know, this is an area where we need to look and investigate further, but we don't actually have the whole picture just because there's a fever, the temperature is high. You know, we have to do more digging. And so learning more about the lived experience and what does it mean to the people that are living in communities that we can identify this way. How do we take that information and elevate their voices so that they can be part of the solutions to these community problems as well?
Yeah, I think it says a lot about stakeholder engagement all along the research trajectory, that even when you're trying to think about the questions, it's really important to have those voices at the table because they bring such an experience that we just don't have, not being part of that community. And it helps to make better questions, which then helps to make better research all along. Even interpreting the data at the end or sharing it is greatly improved by having folks involved. So I like your ideas.
Thanks, Elizabeth.
One of my beliefs is that the healthcare system obviously is is not helping much with disparities when we set up our payment schedules to reward quality metrics. Pay for performance gives extra money to the areas of the healthcare system that are already doing well and not stressed, and then these hospitals that are serving distressed areas get less of the pie. Do you see a way that you could potentially use this area deprivation share as a tool to help Centers for Medicare, I don't know, national payers, state payers, private insurance payers reward the kinds of care that really matter? That you get so much bang for your buck per dollar invested in areas where the equity is lower. Any ideas on that?
I think that's a great question as well, Bruce. We get essentially what we measure for, sometimes in terms of these quality metrics. And so if the goal is to reduce 30-day readmissions, then we may move the needle on that, but are we also then addressing health disparities, which I think is the question that you're raising. And so I would love to see something like area deprivation share even just be considered as part of the metric and adjustment for reimbursement, but then also thinking about taking it steps further beyond that. How do we move the needle on area deprivation share? Are the hospitals and healthcare systems able to make protocols or changes that can, again, partner with community health partners, partnering with these communities to affect some change in that range as well? And so beyond even just using it as an adjustment tool, but also using it as its own potential sort of category of indicators to see how are we changing deprivation, how are we changing disadvantage, how are we promoting health equity, might be an important step in the future as well.
Yeah, I was just going to ask about that. Like, is there information available on how hospitals are connected with community health and primary care and how much communication happens between those, and especially thinking about the rural disparities as well, and thinking of how there might be a lot less interconnectivity happening?
That's a great question. And I think that's something that we haven't been mapping as well, because it's harder to measure. It's part of the problem. And yet I think some of the things that are hardest to measure are probably some of the most important things that really get at what is the root of the problem, what are people's actual experiences with the situation. So trying to find ways that we can map some of those resources. I know that I think it's the AAFP has a neighborhood navigator program, and I'm blanking on the exact name of it now, but that tries to identify resources and how to connect with them. But I don't know if there's a particular measure for how we as the healthcare system are actually performing in terms of our outreach and our connections with our community partners. And that would be fascinating.
And this could go into an extremely interesting conversation, and yet we can't let it because of our timing. So let's all send our virtual applause for a really good, really important good work. And thank you, Dr. Hansman. Our next speaker also has some interest in equity. Dr. Mora Pinson will be speaking on understanding the perceptions of Alzheimer's disease and related dementias among Latinx older adults, a qualitative study. So Maria, Dr. Mora Pinson, take her away.
Thank you so much. I'm just sharing here. I think everybody should be seeing this now. The slides?
Yes, looks good.
Awesome. So yes, we're going to be talking about Latinx and Alzheimer's disease. And a little bit of background first. Dementia is sort of an umbrella term that we use to describe all the symptoms and signs that are related to cognitive decline, memory loss, changes in behaviors that could have many causes. Alzheimer's is the most common cause, being present in about 60 to 80% of the people, but there are other causes of dementia like vascular dementia, frontotemporal dementia, Lewy body dementia, and these are some of the cases. We also have other entities that might cause cognitive decline without being dementia, and I think I always like to give an example of sleep apnea. Somebody with sleep apnea might have some cognitive decline, they might have some cognitive symptoms, but if they start using the CPAP, those symptoms resolve or get much better. So it's not just having memory loss doesn't mean that's automatically dementia. There are many things involved in this term. And this caused a lot of confusion. And I'll explain more about that later and how this affects research. But then when we think about how dementia, Alzheimer's affect communities of color, there's disparities as with almost everything else that we see. Latinos particularly, they are at the risk of developing Alzheimer's disease, and being specific about this is for Alzheimer's disease only statistic is 12% compared to 10% in non-specific whites and 14% in African Americans. But we are expecting that because also the demographic change and the population change, that number is just going up. So by 2060, it's going to be, we're going from 5 million people that we had in 2014 to 14 million of people. So 3 times more people with Alzheimer's disease that we have just a few years ago. And most of these will be individuals of color. But just even looking closer, because 2060 sounds so far away. 2030, by 2030, Latinos and African Americans will make up 40% of the families affected by Alzheimer's disease. And see that most of the terms that I'm using are Alzheimer's. Alzheimer's is the most recognizable term, and it tends to be that all of the statistics are about Alzheimer's. We don't have very good statistics about other terms like dementia. We don't have, or we have cognitive decline without an etiology. That's, for example, the behavioral risk factor survey asks people, have you had any concerns about your memory over the last 12 months? That's the question. It's not if they have Alzheimer's. They ask, do you have asthma? Do you have diabetes? Do you have hypertension? But they don't ask, do you have Alzheimer's? Or have you been diagnosed with dementia? Have you been diagnosed with anything that could be causing cognitive decline? So most of the statistics that I'm showing you is about Alzheimer's disease. But the disparities don't end there. Latinos particularly live with Alzheimer's disease live longer than non-Hispanic whites. They develop symptoms 7 years earlier than non-Hispanic whites. So we're talking that the time frame that we experience Alzheimer's disease tends to be very long. It tends to be usually diagnosed at later stages and less likely to be treated. And here's where it's a couple of things that we're going to be talking a little bit more. The factors that affect these last 2 things are multifactorial. We don't have good tests in Spanish. And even somebody that's fully bilingual, they shouldn't have the same metrics or the same test to say you have dementia. Why? Because it's not the same cognitive capacity or cognitive reserve that somebody that has 2 languages in the brain has compared with somebody that has only 1 language. There's been several studies doing this, for example, for people that's fully bilingual, that they might fail a test in English, but pass it with flying colors in Spanish. Does that mean that they have dementia? There's still, the jury's out there, We're still figuring out what does it mean, bilingual people and their cognitive results. So the diagnosis at a later stage and is likely to be treated are very related to this. So we don't have very good diagnostic tests, we don't have very good services, and we don't have a lot of people trained to apply the tests that we know work for Latinos. Well, then all of this comes down to how do we communicate all of these uncertainties to our community? What do Latinos think when we say all these terms? And when I talk about this with all my mentors in particular, most of them say when they give somebody the diagnosis of Alzheimer's, they say, oh, thank God it's not dementia, or vice versa. They say, oh, you have dementia. Oh, thank God it's not Alzheimer's. So there's a lot of misconceptions out there. And this is important to figure it out, because how do we create the right message? How do we bring people in? How do we express what's happening in a way that people understand if we don't know what do they understand? So this study used a method called card sorting. And these participants received 6 cards, these ones that you're seeing, by mail, because COVID, thank you very much. The plan was to do it in person, but COVID, of course, changed plans. So participants received these 6 cards by mail. Participants were recruited here in Madison. I contacted several organizations like Latino Health Council, the New Bridge group, and shared just a flyer with for the senior citizens, looking for individuals over 50 years old interested in talking to me about what they think about memory problems. After they signed the consent, approved, we set a date, they received these cards on the mail. And the purpose of the cards was to jog their conversations. And you see that I have different things here. I have problemas de la memoria, which is memory problems, dementia, Alzheimer's disease, diabetes, hypertension, and depression or feeling depressed. The reason I could have given them 12 different cards, but I gave the 3 main names that we use sometimes to refer cognitive symptoms as a way to try to differentiate what is different between them, or if there's any difference between them for them. But also, they were asked to organize these cards based on severity. What's the worst? What's the best? Sorry, what's the less bad? And which things would you go to the doctor for? All of this was analyzed using qualitative content analysis. We use for this particular question is that what do Latinos think about Alzheimer's disease and dementia? We use inductive coding, which means it's an open coding. And we use the radar technique, which was developed by Dr. Watkins in Michigan. And I have a couple of examples here. Basically, all the transcripts are transferred to an Excel document. And this Excel document versus master transcript that is narrowed down. As you review the data a couple of times, you start eliminating rows, not from the master transcript, from a copy, eliminating the rows that is not adding anything to your question, that there's no potential to answer your question. And through subsequent coding, you start to define what do they mean and what's the quote or what's that part of that sentence that really express what we're meaning. And the 3 teams came out. The first one, dementia is a precursor of Alzheimer. And this was shared with most of my participants, even those that had a father, family member, or spouse with Alzheimer's. And here's a quote that somebody that has a family member with Alzheimer's refer. When you get older, you start going to dementia. That's where it begins. It begins with dementia. So now one begin to forget, we get lost, and we forget the keys. And I don't know if I forgot the kitchen stuff. This leads to the team number 2. For them, Alzheimer's is a loss of oneself. Most of the participants describe Alzheimer's as a very, very, very late stage of the disease, when people don't remember, cannot take care of themselves. And so I will say that Alzheimer's is more serious than dementia. The person could have dementia, but they function, they can walk, they can eat, they can take care of themselves. But somebody with Alzheimer's, they are completely lost. They lost the connections. Many people refer the word connections to refer to Alzheimer's. Team 3, and this is one of those that I was surprised, happily surprised. everybody agreed that you should go to the doctor or seek help for this. I think the main thing was when. Some people, I think most of my participants refer after other strategies fail, and I have a couple of strategies here. They say, well, if you see that somebody forgot something once or twice, monitor over a month, see if you need to remember that person using notes, that kind of things. And when those things fail, that's when they say, if things keep happening, go to the doctor and ask for help. This might be because of the group that I was talking to is very connected. Maybe they feel comfortable. So the question is this generalizable? I don't know, but this is very encouraging. Implications, language matters. So all the advertisements, all the foundations, all the work that we're doing is using either the word dementia or the word Alzheimer's. People think this is two different situations. People think that doesn't apply to them. Or even people say, oh, somebody was diagnosed with this, but I don't know if this, I don't think they have it because it doesn't fit what they think is Alzheimer's. Future research, so I'm working, all of this came trying to understand, for me particularly, what's the right language? When I'm trying to get people in and talk to them, what's the words that I should use that are more easy to understand and that I could make my message across? Future research, are my results generalizable? So we're going to launch a survey probably in the next month to figure out this and pilot that survey. That includes also a few extra questions about another part that I didn't explain. But in conclusion, there's a lot of things that we don't know. There's a lot of things on Latinos, Alzheimer's, dementia that we don't know. But I think we are in a good track. There's a increase in awareness at least in the Latino community. And this is just one little piece of everything that's happening out there. Thank you very much.
Thank you, Dr. Mora Pinson. I almost want that waterfall image to stay up. It was so beautiful. Or the little video graphic of the grandmother and grandchild with the guitar. That was, this research is extremely important and potentially in potential impact. I'm going to shut up. We've got questions. We've got 7 or 8 minutes for questions and answers before our final talk.
Well, if there's no question, I can share that the picture of the waterfall.
No, please. I'll come up with one. So I'm convinced. You have convinced me that trying to get people to come in for assessment and potential care intervention by using the words dementia and Alzheimer's doesn't work. I imagine it doesn't work with English-speaking populations either, but it certainly looks like it probably doesn't work. What is your inclination of what kind? I know it hasn't been tested yet. You're several steps before really knowing, but what is your inclination of how you might want to target messaging to connect people with resources?
The best way is word of mouth and having a trusted and confident person in the community. That's the best strategy. How that's implemented, there are many ways. For example, physicians still have a very good reputation that only reaches the group that has a primary care physician, but many particular primary care providers sometimes feel afraid of even getting there. It's like, oh, particularly for Latinos, if you ask us how things are going, good. If you don't ask me a particular symptom, I don't think it's important. I think you will ask me about important things. So that's one of the things that physicians are very trustworthy. And if a physician say, hey, have you noticed any problems in your memory? People might be like, well, now that you mention, that's one thing. The other one, reducing the stigma and making more people talk about it in the community. And that's part of having the resources available to deal with the consequences that we're talking. A lot of people is afraid that, oh, my grandpa, my mom, she has a little bit of problem issues, but she takes care of my kids. I'm afraid that the DCS is going to come and take my kids if they know that they are in care of my grandma or my mother. So those are the things that we need to reduce the stigma, having the resources, and so people is feel more open to have these conversations.
Thank you for the presentation. I have a small question. You mentioned that patients or participants said they would go to the physician only like after other strategies fail. Were you able to investigate other strategies?
So those I think it was by age. Most of the strategies that they refer were taking notes, putting reminders in their fridge, putting notes in the cell phone, having a family member calling them or reminding them the things that they needed to do. They were very specific, the tactics, they were related to appointments. And I gave them a case related to somebody that forgot an appointment and what they will do or recommend to somebody to do. So that was very specific to that case. I think if I were going case by case, like what happens if somebody gets lost and how would you address those things? I will get different answers. But that's one of the things that some people, the older the person was, the sooner they will go to the doctor and the less they will be going around. But then it was a little difference is that the younger people thought it was just that you were distracted and they will suggest a few things before going there.
Maria, it's so interesting, this delay in seeking care. I wonder if you could talk a little bit about, from a treatment perspective, what are the advantages of seeking care earlier? And is there any way to message that to the community as important?
Yes, I think as with here the question is there a cost-effective benefit? We don't know that one yet, in the sense that there's benefits, particularly for caregiver and caregiver burden. When they get tools and skills to manage dementia earlier in the disease process and they sort of grow in their skills as they go along, they should have less burden and less chances of having a crisis or that they just seek care for a crisis. That's one of the main things. The caregivers is the ones that have the most benefit. For the patient perspective, the person living with dementia, we know that medications, anticholinergic medications, might have some benefit in delaying progression. Might, against asterisk here, Latinos, we are not really tested in those and all the test issues that we have described. But then there's a couple medications that are coming down the pipeline that are showing some potential benefit. Other things that we're seeing, controlling hypertension correctly, it slows down the progression of dementia. So if we have somebody that we know has some cognitive decline, we diagnose it early, and we really, really take good control of diabetes and blood pressure, we are extending their quality of life and delaying the cognitive decline. So here I say that we don't know if all of these are cost benefit, is because all of those cost comparisons haven't been done. Does it really save money on the long run? We don't know, but it's better for patient health, patient families' emotional health, and for the community.
It just makes me think, as a pediatrician, you know, people are often motivated by how whatever's happening can help someone else. So I almost wonder if the messaging to an adult who's having some memory or whatever issues is, well, you know, this could be helpful for your family in addition to you, and then flipping it around for the caregiver people. Well, we do have some things we could do that would give better quality of life and delay progression. So we're kind of focusing on the benefit to the other person sometimes is helpful. That was fascinating. Thanks.
Thank you.
Maria, I really enjoyed your presentation so much. Thank you for that. I was thinking a little bit about the caregiver piece as well. And I was wondering, when you think about existing patterns, it seems to me that the Latino community, that you have more caregiving, informal caregiving going on with family members living with each other. And so that might have some special, a special need almost to reach out to caregivers in that regard. And I wondered if you had given that thought, I don't know, through churches, through ADRCs, what, even the media.
Yeah, we're still figuring out that one, because, for example, for the media, that's been one of those that it's been sort of conflicted results. A lot of people don't see themselves as caregivers, and we don't use the word caregiver in Latino. So how do you refer? It takes just 30 seconds to say, if you're taking care of a mom, dad, kid, or somebody with disability, it takes a lot of time.
A loved one, taking care of a loved one.
So there's but we're still figuring it out. Certainly, the more the merrier. The caregivers, the caregivers are receiving resources for multiple places, and many of them don't even know it. Like when churches, as you said, Meals on Wheels, all of those different things. Many of them are receiving resources, but they don't self-identify as caregivers. They don't identify anybody in their family as having dementia, so it's very difficult to reach them because of that. But we're working on it. That's one of the questions.
And I know there are more questions and comments, and I'm going to be the bad guy again. This is really important work, but we do have another talk, and we should try to stay on time. So thank you for such important, impactful work, and let's watch your career fly. Okay, our final talk for the 2021 Spring Symposium is something a little different because we have 3 speakers instead of 1, and we have allowed them a little bit more time because of that. Not a heck of a lot more, but for the timing, you feel free to go up to 15 minutes or even a little bit more. 25 is scheduled for the entire thing, and we'd like to have up to 10 minutes or so for talking. And please, I haven't worked with you on this project, so if I get anything wrong, including the pronunciation of your names, please correct me. The title of the talk is Core Cases, Collaborative Outpatient Resident Education, and the speakers are Lashika Yogendran, Alyssa Brulman, and Kelly Heinrich. Take it away.
Perfect. Lashika is going to introduce us, but I'm going to do my best to share my screen, so everyone bear with me for 1 second. This is the ultimate test for me. Okay. And can someone confirm that they're seeing the presentation on their screen? Because I can't
Looks
see
great.
it. Okay, thank you so much. All right.
Perfect. Thank you for that introduction, Bruce. My name is Lashika Yogendran, and I'll let my partners introduce themselves.
I'm Kelly Heinrich. I'm Alyssa Brolman.
So we are the 3 academic fellows. We actually completed our family medicine residency here in Madison, so our family med trained. And our fellowship is a little bit different from the primary care research fellowship. We have perhaps a little bit more clinical time and a little bit more of a focus on clinical teaching in both the inpatient and outpatient environments. Unfortunately, this year, we all had a strong interest in resident education, which led to our combined project that we are excited to share with you guys today. Our project involved creating a new outpatient curriculum called CORE, which is short for Collaborative Outpatient Resident Education.
So I'll start by giving some further background about this project. So there is a decent amount of literature out there that talks about that team-based education and self-directed learning can often improve educational outcomes for learners, and there's some particular focus on this in adult learning settings and medical learning settings. And last year, for the incoming class of first-year residents, the UW Family Medicine residency sought to create a clinic-based orientation model where kind of interwoven with normal orientation activities that first-year residents were also doing some learning specifically surrounding outpatient topics and also engaging in starting outpatient care at their home clinic. So what we worked with other members of the residency to create is a set of 5 cases, which we'll discuss, to teach fundamental outpatient topics. And we use something that's called a flipped classroom approach, which I'm sure many of you have heard about, but we'll talk about in more detail in a moment. And we termed this the Collaborative Outpatient Resident Education, or CORE, educational cases, with the goal of increasing knowledge and also improving medical resource navigation for first-year medical students. So not only to give them a framework with which to start seeing patients, but also to be able to return to resources and use those resources as they build their practice moving forward in residency and beyond. So this graphic is from St. Louis University and just kind of goes over some of the differences between what's termed a traditional classroom versus a flipped classroom approach. A traditional classroom is what many of us may have encountered for the majority of our education. I certainly know that I did. And that's one in which it's much a one-way street between instructor and students. Instructor comes in as the expert in the material for the class. They prepare some material to be delivered during the class time. And then students will often listen, take notes, ask questions, and engage in the class time. But often the work of doing some applied learning can happen after the lecture itself, where there's some degree of a homework or a project in order to try to apply or reiterate some of the learning that was done during the lecture itself. And the flipped classroom model is one in which some of that work actually happens ahead of time, and then the students are really kind of guiding learning in the classroom time itself. So an instructor in this case would prepare some degree of materials to be distributed to learners before class. And the idea is that students are engaged with reviewing some of that learning prior to showing up for whatever the actual class session is. And then class time or kind of togetherness time from a learner's perspective is devoted to applied learning, doing activities, and kind of engaging in higher order thinking tasks in order to take what has already been given to them and trying to kind of do some more applied practice. And the instructor is still there and present at the time of the class in order to engage with learners, help guide the learning, but that students are really more the drivers of the pace of the learning as well. And the instructor is there more as a supplementary mentor in some sense.
So there definitely has been research into the flipped classroom model and comparing it to the traditional classroom model. There's been more robust development in this field since 2012. The settings for these studies have typically ranged from high school to graduate school. The literature out there is a bit mixed. There was a meta-analysis published in 2019 that looked at 114 studies comparing flipped versus traditional classroom methods in secondary and post-secondary education. Looking at these studies, the authors found a small but significant positive effect size on assessed learning outcomes. So things like tests, quizzes, other formal assessment methods. They noted no difference in effect on student satisfaction when compared to traditional classroom methods, which was interesting. And then in a literature review done in 2015, the authors found that the majority of papers showed that students in flipped classroom models either had higher scores than students in traditional classroom models, or that the difference was not statistically significant. Notably, it was rare to find in these studies that students in a flipped classroom model were doing significantly worse compared to the traditional classroom counterparts. So I think the main takeaway of this is that flipped classroom teaching doesn't appear to do any harm based on the research available. And kind of looking at this, as a result, we kind of thought that this method of teaching and learning could be an interesting thing to pilot with our interns this past year as they were getting adjusted to residency and working in a clinic and working on improving their knowledge about patient topics.
So with this in mind, we set out to teach fundamental outpatient topics to family medicine interns using a flipped classroom model. We did this by first informally surveying the residents to help identify 5 outpatient topics that were felt to be important for family medicine residents to have a good grasp on early in their intern year. Great. Some of the topics identified seem to lend themselves well to a combined approach, as was the case with hypertension and hyperlipidemia and COPD and asthma. Residents also identified adult preventative medicine, pediatric preventative medicine, and diabetes as important topics. Once our topics were identified, we created 1 to 2 cases for each topic, as well as a series of case-based questions, and identified a small set of online resources that residents were asked to utilize when working through the cases. We then developed standardized pre- and post-case surveys, which interns completed for each case. Surveys used a 5-point Likert scale to determine confidence in medical knowledge and familiarity with resources related to each topic prior to the course session and then after the course session, as well as the likelihood of the case discussion impacting their future practice. And then once all sessions were held, we analyzed the results with the assistance of a statistician using Mann-Whitney tests of paired and pooled survey response data. The core cases, the suggested online resources, and the pre-case survey were distributed to residents via email 1 week prior to the core case discussion. Due to the size of the group and COVID constraints, 3 of the sessions, the diabetes session, the COPD asthma session, and the hypertension hyperlipidemia session were held virtually, while the adult preventative medicine session and pediatric preventative medicine session were held in person. On the day of the case discussion, the residents were broken into small groups. They were asked to identify a leader to help facilitate the discussion, and the case was then discussed. And then they were given the post-case survey to complete. There was a faculty facilitator present for each case discussion, but that person was instructed to act only as a guide.
So we're just going to go through some of those components which Kelly just discussed in a bit more detail. The pre-survey, here's just a sample of it here. It was fairly simple. We did ask residents to choose the respective case that they were about to do, so the topic like COPD, asthma, and then also to create a unique identifier. And the goal was to be able to use that unique identifier to pair pre and post-survey responses. For the most part, we got the same unique identifier for both pre and post, though not always consistently. And here are only 2 pre-survey questions. So it's a Likert scale asking residents to rate between strongly disagree and strongly agree for the following 2 statements. I feel confident in my knowledge of this topic in the outpatient setting, and I am familiar with resources related to this topic in the outpatient setting. And again, the goal with this pre-survey is that they would complete the pre-survey prior to opening the case, prior to reviewing the resources that we gave them for the core case itself. And then there was another area for just free text if residents were interested in leaving any other additional comments.
Each case had a list of objectives as well as a set of suggested online resources to utilize when working through the case. When possible, these resources were sent to residents as a PDF. We also tried to include smartphone apps and embedded health link tools when relevant, hoping to have the residents create for themselves a toolkit that they could come back to in the future when these topics came up in real life.
And so here we have the beginning of a sample case. This one specifically is addressing the well woman visit. We chose to use patient cases as the way for residents to work through clinical information, as they tend to lend themselves to being more interactive and promoting discussion amongst the learners. We created various questions that we felt best assess the objectives we made for each case. And as we discussed previously, learners would work through the cases before the session, and a leader would be assigned at the session and would lead the case discussion. And then as you can see with this, this page illustrates our emphasis on learners looking into the various resources for clinical guidelines and protocols, which was also one of our objectives, as well as measurable items as part of our pre and post surveys.
So now looking to the post survey, again, residents were asked to select the respective case that they had just completed, as well as use ideally their same unique identifier from the pre-survey. And then we asked residents to once again rate their level of agreement with the statements surrounding confidence and knowledge of the topic that was just discussed, as well as familiarity with resources related to that topic. And then there were 3 additional statements that we asked them to complete. And one was kind of evaluating if this core case felt relevant to them as a family medicine physician, if they felt it would impact care or impact the care that they would provide to patients in the future. And then one statement that asked them to consider if the collaborative learning style of the core case was more beneficial than a traditional lecture format. And again, the Likert scale went just a 5-point scale from strongly disagree, which was assigned 1 point or the least point value, to strongly agree, which was assigned 5 points or the most point value.
And then our data is presented in these 3 tables. We had 18 interns participate in the 5 core case sessions, though the data in the first 2 tables only reflects the residents for whom we had both pre and post case survey responses. The first 2 tables look at paired pre and post case survey data. The first column of each table shows the average point value assigned by the resident using the 5-point Likert scale in response to the pre-case survey question. For the first table, I feel confident in my medical knowledge of this topic in the outpatient setting. And in the second table, I'm familiar with resources related to this topic in the outpatient setting. The second column in each table shows the average point value assigned by the resident on the post-case survey for the same question. We have standard deviation noted in parentheses, and then the third column shows the average point difference between the pre and post case survey, and then we have the p-value in the last column. And you can see that respondents noted a statistically significant improvement in confidence in medical knowledge and resource familiarity for 4 out of the 5 cases, basically all the cases except for the COPD asthma case, which did show a trend in improvement that was not statistically significant. This case we'll talk about later. It was the final core case and had the smallest response rate, which likely contributed to the large standard deviation that we see for that case as well. And then this last table shows the data from the post-case survey. Respondents either agreed or strongly agreed that the core case was relevant, would impact their future practice, and that the collaborative structure was preferable over a traditional lecture format.
So looking to this slide, this is just represents some of the data that shows how there were varying variations in how the surveys were completed in terms of the pre and post survey completion, as well as the time between pre and post survey completion. On the left, you'll see a graphical representation of this data. So on the vertical axis is the unique identifier for every resident, and on the horizontal axis, the response date. Any plus sign is indicative of a pre-survey completion, and any circle is indicative of a post-survey completion. And what you'll notice is that sometimes that plus and the dot actually overlap at that they were completed at nearly the same time or on the same date. And then sometimes there's variations as many as up to a week between pre and post-survey response. And that likely represents the fact that often we would prompt people at various times to complete the pre-survey. So perhaps a resident would do that at the time that the initial email was sent out, or maybe they would do that closer to the date of the core case itself. And then on the right-hand side, you'll see, again, that we had a decent amount of variation between the cases of the number of paired pre and post surveys, as well as some responses where we only had a pre-survey or only a post-survey present. And again, there were a total of 18 residents, so there are times in which there were no responses from a particular resident, either pre or post.
So based on our data, I think we can say that the core case classroom curriculum did help improve interns' self-reported knowledge of and familiarity with the resources related to selected outpatient topics. The interns in our study prefer the interactive form of the core cases as opposed to a more traditional classroom model. One of the things that we certainly took away from this is that structured self-directed learning could be useful to in residency education. Certainly in the past year, we've had to be more creative when it comes to learning, and so different ways of teaching will be helpful in the future as we continue to work on improving residency education and accommodating different kinds of learners. We certainly had limitations to this project. I think the most obvious one is that we had a small sample size. As we've alluded to previously, each year there are only 18 interns. That was the maximum pool of responses we'd be able to work with. And even within that small pool, we dealt with survey fatigue, where interns wouldn't always submit the pre-survey, post-survey, or both. This certainly played a role in our data, particularly for the COPD and asthma case, where we only ended up having 5 paired responses. Not surprisingly, this was the last core case that we did. As Alyssa also discussed in our more colorful graph, we did have inconsistent timing with pre and post survey completion, so this could have affected our data as well. Lastly, we thought this could be a limitation, but due to the pandemic, we had to do a mix of in-person as well as virtual sessions via Canvas. I think we all know that interactive case-to-session can be difficult to achieve virtually, so that could have affected how interns viewed the core case curriculum when they were submitting post-survey data.
Overall, the cases were well liked by the residents and will continue to be implemented as part of intern orientation in future years. We are passing the cases on to a new group of facilitators for upcoming orientation this summer. Some future directions for this project could include creating additional cases such as a musculoskeletal case, women's health case, or mental health case, as well as continuing to evaluate the impact over additional cohorts of residents.
So that is all we have to present with you today, but we would be remiss if we did not thank key players within this project, the first of whom is Thomas Hahn, who's one of the associate program directors within the residency, and so has been a mentor to us during our residency years, but particularly over this last year as well. He's very engaged in resident education and helped us build the idea for these cases, as well as has helped with creating ways to consider how to creatively analyze this, as well as think about the future initiatives as this moves forward in future iterations of residency classes. Jen Bursler is the department statistician without whom we would not have any of the graphics that we shared with you today. So we incredibly thank her for her skill and help there. And then finally, Serena Schrager, who is the director of the academic fellowship and has been a mentor to the three of us over the past year. We certainly greatly appreciate, because she has kept us continuing to question what we could do next and continue to kind of push our efforts over the last year. So we've really appreciated working with her as well. Here is just a list of the citations which we sourced for this particular presentation. And we certainly, I will exit out of the full screen mode and we can discuss any questions or ideas that anyone would like to share.
Wow. Thank you so much for your presentation. We have as much time as we want for question and answers because yours was the last of the day. Other than people maybe wanting to get lunch eventually or move on with their lives, we can go for this conversation. So I'm just going to start it out by saying, I don't think I've ever seen a presentation that was coordinated as well between three speakers within this kind of time frame. So if I had a gold medal award to give to each of you for that, I mean, I think you must have rehearsed, right? Yeah, that's very impressive. And really important work about residency education, which is near and dear to many of us on the screen, maybe not everybody, but residency education is so important. My first question is just kind of a procedural one. I think I heard through the grapevine that you either already presented this at some kind of conference or are planning to. So if you could just give us the details of that. And then the question is, and are you planning to publish?
So we did do kind of a virtual poster presentation at STFM, which is one of the teaching conferences. It was their annual spring conference, I think a week or two ago now. So it was more of kind of a virtual poster presentation. I think we all have aspirations to publish. I think Primer is one of the STFM journals that is focused on academic family medicine, and that was something that Tom Hahn had recommended to us as something to pursue. So I think aspirationally, that's something we would love to do. We'll just have to see how things pan out. Because this was very much a pilot study, and I think it would be interesting to get more data as future cohorts pass through each year.
And I don't want to put her on the spot, but Dr. Serena Schrager is one of the most gifted helping people publish faculty that we have, gifted and experienced. So just a hint.
Yes, we are fortunate to have her.
Yeah, Bruce, is that something that I can put on my CV? Gifted at helping people publish. I just want to say, I thought you guys did such a great job of being really thoughtful and planning to evaluate this, and just from before you even started. And I don't know if Tom talked to you about that or I talked to you about that, but I was very impressed by your thoughtfulness and your thoroughness in doing these evaluations. So I had a couple questions. During the virtual poster, did anybody talk to you about trying this at their program? So that's number one. And number two would be, if we do the same program again, how would you guys change it so that you would have better attendance and engagement with that fifth case? Or is 5 too many?
I can speak to some of that, and maybe Kelly and Lashika can supplement. How does that sound? I will say that I think both you, Serena, and Tom were instrumental in reminding us that it's probably good for us to consider an evaluative component for this and thinking about this as an academic project. And I will acknowledge that I think in presenting to you all today, we all had a little bit of self-doubt because you all are so invested in research within the primary care field, and so we wanted to honor those efforts and also acknowledge that that's not our kind of core skill set. So we appreciate everyone kind of engaging with us today. With regards to the STFM poster, so this was a virtual poster, and there was no opportunity for kind of like discussion at that time. It was kind of people cycling in and out of posters. I have been at other conferences recently with virtual poster presentations where that model has been a little bit different. But as far as I know, we haven't received any like direct contact from anyone else from STFM, like who had seen the poster who had questions. So as of right now, no other institutions have really kind of discussed that, but maybe that would change if we were to publish something in Primer. Maybe the publicity with that would be a little bit different. And then I am forgetting the second part of the question. I don't know if either of my team members remembers.
Yeah, so it was about that fifth case. I don't really know what went wrong with that fifth case. I think there was like probably a lot of different factors at play. I think so. It did feel like 5 was a lot of cases in the amount of time that we did it in. And I think part of that was also because some of them we did multiple times. So like from our perspective, we did I think 8 sessions over 3 weeks. So it did start to feel a little bit like a lot. I think some of the topics are really important for the beginning of the year. And I think that it's a good education model and could potentially be spaced out to, allow for a little bit of different timing in between the cases. I think also if this continues in the future, we don't always need to be evaluating the project, right? Like we can say that we think this works well or people like it. And I think that at that point, the survey fatigue, it wouldn't be a problem anymore because we wouldn't need as many survey responses. So the learners could just really focus on the case, the pre-reading, and then participating.
Yeah. Oh.
I was going to say, so this is David Felton, and I've actually done a fair amount of educational research. And so it is critical to think about before what you're going to evaluate. And one of the things that I also had the same question of, is this too many cases? Are you trying to teach content or are you trying to teach resources? And that may be different. So if you're teaching resources, you want them to get that early on, right? So that they're able to use those resources throughout their intern year. But if you're teaching content, that may not be so time critical. So it could be that there are 3 cases that teach resources that are really critical early on, and then the others could potentially be spread out. So that's one thing to think about. The other is, so this sounds like it takes a lot of resources on your part. And so understanding, because you could also just send them cases and, and a list of resources, and that's the education. So thinking about what benefits you think you're getting by doing it this way and how you might evaluate those. So is it better knowledge that you're looking at? Is it better understanding of available resources? Is it so really trying to think about that and trying to look at potentially whether it's knowledge tests, whether it's actually looking at the electronic health record and seeing how they care for patients. That's like the holy grail of educational research, is to show that you actually change what they do versus that they know something. And in terms of looking for other other residency programs. So in the past, I've done that through just, colleagues and knowledge, but working with your program directors here, there probably are listservs or other things that most of the program directors are on, and just putting out feelers and seeing if anyone's interested. I'm sure there will be lots of programs that are interested in this. Now, the resources, I don't know if some of your resources are UW specific, which obviously then you have to figure out, but it seems like this could be reasonably easily adapted into other residencies as well, and I would imagine there'd be a lot of interest.
Thank you so much for your thoughts. That's very much appreciated. I think it's a really interesting point about separating resources from knowledge. We certainly could have been a little ambitious in trying to combine the two, but reflecting on your comments further, I feel like there's definitely room to maybe focus on more of the resources at the beginning, kind of giving a man a fishing rod to fish as opposed to teaching him how to fish, and then adding the knowledge later. We didn't necessarily include this specifically in the presentation, but we also tried to incorporate Epic HealthLink smart sets and smart phrases as well. So kind of in terms of resources as well as kind of more practical tips as well. But that's an interesting idea to ponder, of kind of separating and having this be more longitudinal as opposed to the very short span of time that we have this as part of the clinic orientation. Thank you.
I was just going to ask, like, in addition to survey data, have you thought about other indicators of like engagement and the importance of the interactive component of your program, and seeing, how much like active discussion and sharing of ideas when they're processing these different cases, how much that actually happens, and how that then leads to improved care of their patients?
Yeah, I think that's something that we witnessed by just kind of being, we were, each of us served as a facilitator for every case. So we were kind of present for those resident discussions, but certainly didn't do anything kind of beyond being present to kind of evaluate the level of kind of engagement and discussion. That is one thing that I will say that, like, especially in the virtual format, just doesn't seem as smooth, especially with, this group in particular of first-year residents, is just still getting to know each other, and they hadn't even really, I think, even met a ton in person yet. So some of the like dynamic that you normally expect of a class of learners, especially a residency class of learners, I think was very different this year than maybe present in future years, where there may be less virtual learning, as well as there might be kind of more of a community of learners, or a different community of learners than I think this particular unique class was, just given COVID and just kind of the total upheaval that had happened for residency orientation and residency learning. I think, I'm not sure that this year is going to be representative of future years, but I think in future years that's a really good question to kind of consider, is how to kind of engage with the level of that discussion between residents, how to kind of measure that or think about that a little bit more critically, because I don't think we really did that thinking.
If no more questions, this would be a fine time to provide our gratitude and exuberance for a real amazingly choreographed. I think you must have all been in drama in high school and college, and because I don't know people who can follow scripts as well. Really impressive. Before we disband for the day, it is my duty to remind you that you may not leave this WebEx until you have provided helpful feedback to our full list of speakers. If you happen to miss one or two talks, then please don't make up false data. People who do that get thrown into research purgatory or maybe beyond. But please do give feedback for our speakers, aiming to help them become even more outstanding. The links are all in your chat. And in addition to links for Qualtrics, and they're really small, I filled out all but one now, there's a Qualtrics link for the overall symposium evaluation. Dr. Feldstein, Cox, and I, and Swords will all be looking at that information closely and trying to come up with a even better way to run this kind of a symposium next December, when if I were a praying man, I would hope that the goddess would give us a in-person symposium with food and drink. And I will turn this over at the end to Dave and Elizabeth for final remarks, conversation wrap up.
Well, I can start it. So every time it's just so wonderful to see all the great work that everyone's doing and how it progresses. So we have the works in progress, and we kind of see snippets, and then to see people's final presentations. And, I was thinking about, one of the questions is about areas for improvement, and the presentations were really outstanding this year. I mean, from the slides to the information and how well it was boiled down. So everyone must have done a lot of work. So it is really appreciated. We really love this opportunity to see what everyone's doing, and it's such a wide, range of topics and research. And as a generalist, I love that. And so just thank you to everyone and all your hard work, and it's been really great as always.
And I'll just say ditto. Everyone go enjoy your lunch. It was just a fantastic morning. Thank you.
All right. Good to see you all. Thank you for persevering. Really, really good stuff. And feel free to use email or other methods for contacting each other and us. And onward with your lives. Really nice, a nice place to cap the semester. Bye-bye.